Hello, hi, and greetings everyone. This is Dilip. Welcome back once again to the afternoon session. We have been discussing on the Stemi and its management. So if sufficient number of people have joined, let us start with our further discussion on the complications of Stemi. Okay. So you can, if everyone has joined, you can tell just a hi or yes or whatever you want to tell so that we can start with the session. Okay, cool. So there are some sufficient sizable number of people. Great. So let us start with the treatment of the complications of the Stemi. So we have seen the actual treatment of Stemi. Let us see the complications. So, I mean, whatever may be the case, what is going to the nutshell of the treatment? So let me tell, because if there are some UG kids are also there who must be knowing what is the nutshell of whatever we have told. So first of all, when you are dealing with an ACS, first stabilize the patient. That's the first thing that you need to do. Once you stabilized, you are going to give anticoagulation. Irrespective of that, suppose in case if it's a STEMI, you're going to go for a PCI or a thrombolysis, which means you're going to do reperfusion. If it's going to be a high risk STEMI, high risk NSTSS, high risk STEMI and stable angina, you're going to proceed with a coronary angiogram. Otherwise, you're not going to do a coronary angiogram. So if somebody asks you what is the nutshell of whatever we learned since the morning, this is going to be the nutshell. You know how to stabilize them, start a DAPT, then you're going to start anticoagulation. Suppose if you're dealing with a high risk NSTSS, then you need to proceed towards a coronary angiogram. Suppose if you're dealing with the STEMI, then you're going to do a reperfusion. Am I clear? So I think now this must sort out. So what we really have to do. Are you understanding or not? So, I mean, whatever we have discussed in the afternoon session and now whatever I told you as a nutshell. So if you understand this, then we can move on to the next thing. So that is on the complications of STEMI, because STEMI is going to produce more in-hospital complications compared to that of the NSTSS. We know that. So what are the complications of STEMI? Before going in, before going to the complications of a STEMI, how did you make a diagnosis of a STEMI, and is there any contraindications for EST, exercise stress test? Yes, there are contraindications. I'll come back to that, man. We have not yet discussed the EST. I mean, let me finish off these things first. Then we are going on to the chronic stable angina part. In that, I'll be discussing in detail about what you mean by exercise stress test and what is Duke's treadmill score and all this stuff. So don't, interact right now. So once we finish off completely, then we can have our doubts and discussions. And I think some of the people are asking the contraindications for thrombolysis. What are the contraindications for thrombolysis? You can split the contraindications into absolute and relative contraindications. Yeah, absolute, and you tend to have something called relative contraindication. What are the absolute contraindications? I mean, usually the first point is the most important. Whenever you talk about an absolute contraindication, any prior intracranial hemorrhage, any time in life is going to be the number one contraindication, and that should be always remembered. It has a legal implication as well. That's why. So suppose if the patient is having any untreated space occupying lesion in the brain, like for example, if they're having a neoplasm, a brain neoplasm, or the patient is having untreated aneurysm, or the patient is having an untreated AV malformation. See, aneurysm is significant if it's more than 1 centimeter. So if it's less than 1 centimeter, okay, you can still go ahead. But if it's more than 2 centimeter, definitely, or maybe more than 1 centimeter, definitely it's a contraindication. So any untreated neoplasm in the brain or any aneurysm in the brain or any AV malformation in the brain can be considered as an absolute contraindication as well. Third thing is, in the last 3 months, if you had an ischemic stroke, or if the patient had any evidence of head injury in the last 3 months, so that becomes an absolute contraindication. So head injury in the sense, this will apply, this you can extrapolate to some surgeries also. For example, some cranial surgeries or probably some spinal surgeries. So you can extrapolate that also. Even when you do a cranial or a spinal surgery, that is equivalent to that of a head injury only, but you are inducing iatrogenically. Anyway, so you can extrapolate and understand. So in the last 3 months, if the patient had ischemic stroke, in the last 3 months, if the patient had a closed head injury, in the last 3 months, if the patient had any cranial or spinal surgery, then you can think it as a contraindication. But this cranial or spinal surgery has been revised a little bit. They have told in the last 2 months, if you had cranial or spinal surgery, that's a new revision in 2019. So if you want to know, you can note that also. But previously, it was only 3 months. And apart from that, if the patient is having any active bleeding, I mean, in the sense, it's not like bleeding that is coming from a small cut in the skin or something. So we are talking about active internal bleeding like hematemesis, melena, hemoptysis, hematochezia. So any active internal bleeding is definitely a contraindication. The patient is having a suspected aortic dissection. After the ICH part, if there is one point that is the most important, that is this point, that is suspected aortic dissection. If the patient is having aortic dissection, you should not touch any antiplatelet, anticoagulant, or fibrinolytic agents. You should never do that. Clear? You should not use any kind of anticoagulation, antiplatelet, or thrombolytic agents. Then if the patient is having severe and uncontrolled hypertension, because of high risk of bleeding, this is an optional one. So I can put it in a different color. So 7th one. So this will apply only if the patient has been used streptokinase. Suppose if you have used streptokinase already, within next 6 months, to use streptokinase is a contraindication, which means in the next 6 months, to use STK is a contraindication. You cannot use streptokinase within the period of 6 months after its initial use. That is because of the risk of allergy, because it's a bacterial product. So remember, initially it was around 6 years, but right now it has come down to 6 months. In the next 6 months, you should not use streptokinase. That is the key. Suppose if you want to reuse streptokinase within 6 months with the prior use of streptokinase, then that becomes a contraindication. Very important point. That is for streptokinase only, not for other thrombolytic agents. What are the relative contraindications? Not uncontrolled hypertension, but if the patient is having a BP of more than 180/110, either systolic or diastolic, BP is more than 180/110 at the time of presentation. Remember, when BP is high and a patient presents with an acute coronary syndrome, it is a hypertensive emergency. So why it is a relative contraindication? Because this is something which can be rapidly changed. Not a problem. So if you start some infusions of antihypertensives like nitroglycerin or probably even labetalol sometimes, it can respond very nicely. So that is the reason why this is something changeable. So that's why it's a relative contraindication. Then second, if you are having a ischemic stroke, already we know ischemic stroke within the last 3 months is an absolute contraindication. If it happened more than 3 months, is going to be relative contraindication. Third thing is pregnancy. Remember, it's only a relative contraindication. And at the same time, many students ask me about menstruation. Menstruation is only not a contraindication. Menstruation previously was relative, but currently it's very clear that menstruation is not a contraindication. Pregnancy alone is a relative contraindication, but still not absolute. And what is that? Your lactation, once again, is not a contraindication. So lactation, menstruation currently are removed from the contraindications. Pregnancy still is there, but it's only a relative contraindication. It's not an absolute contraindication. And if you have a non-compressible vascular punctures, so this is true especially when you have done a arterial puncture for ABG, or if you have done an arterial puncture in the femoral artery for taking a blood for ABG, that time if it's not compressible and it's oozing continuously, so that's called non-compressible vascular punctures, and that's one of the important relative contraindications. Even though not an absolute contraindication, it's a relative contraindication. Apart from that, if the patient has been given an extensive CPR, like if they're given CPR for more than 10 minutes, that is once again a relative contraindication. And at the same time, if the patient has gone for some major surgery in the last 3 weeks, if the patient has gone for some major surgery or a major trauma, like a polytrauma, road traffic accident, if the patient had something like that in the last 3 weeks, that becomes a relative contraindication as well. The patient is currently using anticoagulants like warfarin, Novax. I mean, actually, this is an absolute contraindication for stroke thrombolysis, but in MI thrombolysis, it becomes a relative contraindication. Current anticoagulant use, like warfarin or NOACs. And apart from that, in the last 2 to 4 weeks, if the patient had any internal bleeding, internal bleeding. For example, a bleeding peptic ulcer, or if the patient is having an active peptic ulcer disease, that becomes a relative contraindication. All these are due to increased risk of bleeding only. That's why we are using this as contraindications. Suppose if you are using streptokinase in the past, any prior exposure, it becomes a relative contraindication. So remember, in the first 6 months, it's an absolute contraindication. But relative means any prior exposure beyond 6 months, which means even after 6 months, any prior exposure to streptokinase becomes a relative contraindication, because always there is a risk of allergy which can wake up again. But in the first 6 months, it's going to be a definite contraindication. So if somebody wants to know the absolute and relative contraindications, these are the things that you need to know. So of course, the first one, the prior ICH, is going to be the most important. Then ischemic stroke in the last 3 months have been asked multiple times. Then suspect artery dissection, I don't know how to tell, that's one of the most important contraindications. Then BP cutoff has been asked multiple times in the exams. Then they've asked about the streptokinase use, again, which is very, very important. And CPR more than 10 minutes also is very, very important. So whatever I've ticked here are probable or already asked questions in the exams. Remaining things, if you want, you can, like mug it up and go for the exams. But anyway, these checklists, I don't really mug up, because this is some checklist that is available in every ambulance. 8 and 9 are hiding. Okay. After 2 to 4 weeks, if the patient is having within last 2 to 4 weeks, the patient is having any internal bleeding evidence, or if the patient is having active peptic ulcer disease, that becomes a contraindication. And for streptokinase, any prior streptokinase use becomes a contraindication. Clear? All right. So these are the contraindications to thrombolysis, which I have discussed which I discussed some time back. Now, BP more than 180 or less than, more than or equal to, why it should be less than? BP more than or equal to 180/110 is a contraindication, not less than 180/110. It's a relative contraindication. Then what else you need to know? So we need to know the complications of myocardial infarction. The first complication is going to be the cardiogenic shock. That's going to be the complication. Complication of Stemi. Remember, cardiogenic shock is the most common cause of in-hospital mortality in a patient with a Stemi. Out-of-hospital death in a Stemi is usually due to arrhythmias, but inside the hospital, obviously, like doctors are there to revert these arrhythmias if they are happening. So in hospital, usual common cause of death is cardiogenic shock. So that's what we're going to see. Cardiac failure and cardiogenic shock. So cardiac failure can happen under 2 settings. It can be either a LV failure, it can be a RV failure, or it can happen in the setting of mechanical complications also. Mechanical complications. So if you think about an LV failure, that is left ventricular failure, usually, very commonly, it happens in the setting of an anterior wall myocardial infarction. Anterior MA is the usual reason for developing a LV failure. And if they ask you how you're going to treat it, so treatment is very simple. First of all, this ventricle is not able to pump enough blood because it's getting overloaded. So you have to reduce the preload first. How do you reduce the preload? It's by giving venodilator, so that with these patients, usually clinical features will be that of a pulmonary edema. That's how they will have. Most of them will have a pulmonary edema, and they might have an associated shock. Pulmonary congestion will be there. That's how they're going to present. So you have to reduce the pulmonary edema by reducing the preload and movement of blood into the lungs. At the same time, you have to give rest to the heart by reducing the preload to the heart. So we are going to reduce the preload because you're going to start with nitrates. And you can give active diuresis because most of the patients will be in pulmonary edema. And you have to give less fluids, which means fluid overload should never be done. In fact, you have to give less fluids than what you're supposed to give for a normal patient. Plus or minus, I can use inotropes to pump the blood out of the heart, of the failing heart, better way. So what are the inotropes that you will prefer? So standard inotropes, if the patient is having a normal blood pressure, then I can use dobutamine or levosimendan. If the patient is having hypotension and shock, in this scenario, I'll be usually using noradrenaline or dopamine. Remember, noradrenaline and dopamine can be used here also. It's not like you cannot use noradrenaline and dopamine there. But in general, like for a heart failure with a normal blood pressure, we'll be thinking about using a dobutamine or levosimendan. Of course, the best method to treat these patients is reperfusion, and the best way to reperfuse is PPCA, that is primary percutaneous coronary intervention. PCA is the best way to reperfuse these kind of patients. Suppose if your reperfusion is delayed, it is going to take some time. So what you can do? You can do something in the interim. What are the interim devices that are available? This is very, very important, especially if the patient is in shock. Especially if the patient is in cardiogenic shock, this is a very important treatment, interim treatment, till you take the patient for reperfusion. So what is the interim treatment? There are two options are there. One is IABP, that is intra-aortic balloon counterpulsation, and second is axial flow systems. Axial flow pumps. These are support pumps, like for example, you have something called the Impala device. Axial flow pumps. So these are the interim measures, but remember both these techniques have not shown any improvement in the survival, which means the mortality remains the same if you are taking the patient for early reperfusion. Suppose if you compare IABP versus early reperfusion, there are two trials, IABP 1 and IABP 2 trials are there. Both the trials have shown no significant benefit out of IABP compared to the early reperfusion and standard care. So, but anyways, if your reperfusion is delayed a little bit, then in that setting, you can maintain the perfusion through intra-aortic balloon counterpulsation. Remember, IABP is somewhere you have a balloon that will be inflated in the aorta during the diastole. Remember, during the systole, you cannot inflate the pump, because if you inflate the balloon during the systole, like your P in IABP, intra-aortic balloon counterpulsation. That's IABP. Impala is the same as LVAD. Yeah, axial flow pumps is the same as LVAD. It's axial flow pumps only. It's not exactly similar. It's similar to that. So that is left ventricular assist device you're talking about. Okay. So IABP is very commonly used in our setting. So we use in and out IABP, very, very common. So especially when you want to shift the patient to PCA, IABP is the way to go. Any patient cardiogenic shock. It can be used in RV failure, it can be used in LV failure, can be used anywhere. Because that if the balloon is inflated during the diastole, the diastolic pressure will increase. Increased diastolic pressure will perfuse the organs better. At the same time, it will augment the cardiac output by approximately 500 ml per minute. By you can tell half liter per minute. It's going to improve the cardiac index also, because you're perfusing the organs better. At the same time, because coronaries fill predominantly during diastole, so your balloon inflation, because it increases the coronary perfusion, they can be helpful in reducing the size of the infarct also. So they can maintain coronary perfusion for a long time as well. So that's the advantage of using an IABP, intra-aortic balloon counterpulsations. Impala is very good. It's like an LVAD. Impala is going to offer an additional like cardiac output of approximately 3 to 5 liters per minute. It can improve the cardiac output by a great level. But both these pumps have not shown to improve survival significantly. They're not shown to alter the mortality significantly if you are doing early perfusion. So which means very clear, it should be added only if your reperfusion is delayed a little bit and you have no other option, then you can use IABP or axial flow pumps. In our hospital, we always prefer IABP. Suppose if IABP is not available in your setting, then there's no other option. You have to maintain with the inotropic agents like norethindrone, dopamine only. Then right ventricular failure usually happens in the setting of an inferior valve myocardial infarction. It's an inferior MI. So that's where you're going to get right ventricular failure commonly, especially if it's a proximal RCA occlusion. Many times. If it's a proximal right coronary artery occlusion, then the marginal branches, which you are discussing in the first day, that will be affected, and because of that, you will be having a right ventricular failure. And apart from that, which means what is the MI that should have because of proximal RCA? It's a right ventricular MI that is usually coming with an inferior MI. That is the reason for development of RV failure in the states. And how will you treat these patients? In this particular patients, you have to treat by actually optimizing the preload, which means you have to see the JVP. The JVP is less than 12 millimeters of mercury. Then you can go ahead with fluids, because in that setting, you have to optimize the preload and you have to increase the fluids, because fluids might increase the contractility of the right ventricle so that you can push more blood towards the left side. So fluids are the key here. And at the same time, if the JVP is more than 12, in this setting, it's better to use inotropic agents because already the patient is loaded here. So in this setting, you use inotropes using the same principle. If it's normal BP, then you can go for dobutamine. If it's low BP, then you can go for noradrenaline or dopamine. So noradrenaline is the better choice in that setting. And at the same time, most of the times, whenever you have a right coronary artery involvement, there is one problem that you will face very often because of right coronary artery involvement is the fact that they might develop heart blocks, especially complete heart blocks and all is extremely common with inferior MI. That is with the right coronary artery occlusion because right coronary artery is the one that supplies the SA node as well as the AV node in majority of the cases. We studied already. So conduction blocks are extremely common, especially AV blocks are very common. Suppose if AV blocks are there, then you can try doing a pacing also because it all depends on what type of failure you're dealing with because Riju is asking giving fluids will increase the risk of overload. No, it's not really. So if you have left heart, that's going to end towards the right heart. I mean, right heart is going to end towards the left heart. And in fact, this is the venous inflow, SVC and IVC. And your capillary system, and you have the aorta here. Okay, you can draw just like that. You have the aorta here. Aorta, then you get the SVC, IVC. Then you get the pulmonary veins, you get the pulmonary artery. And you have a lungs here. So if you see, whenever the right ventricular failure is there, whenever the right ventricle fails, the main problem is it will not be able to maintain the preload of the left side because right ventricle is the one that maintains the preload on the left side also. That is the one that's going to pump the blood into the aorta. Suppose if the right ventricle is failed in this condition, you will not be pushing enough blood into the left side. So that is why you get low cardiac output and hypotension. Suppose if you want to really maintain a good flow or a good right ventricular flow, then it's better to give fluids. So that by Frank-Starling law, more preload, if the heart has not failed significantly, then definitely it will push more blood into the right side so that more blood into the left side so that your left ventricular preload will increase and so that they can increase the cardiac output. But the problem here is But the main problem here is, what will you do if it's a left ventricular failure? If it's a left ventricular failure, you can't do that. I'll tell you why you can't do that. Suppose if you're going to have a left ventricular failure, the fluid is going to accumulate in this area. Fluid is going to accumulate here. Suppose if you are increasing the preload and already there will be a lot of fluid that is accumulating in the pulmonary circuit also. So already if there is a lot of fluid that is accumulating in the pulmonary circuit, if you give more and more fluid, this fluid can't go back into the left heart itself in the first place and they will start getting stasis in the lung circulation and they will cause more and more pulmonary edema. So that is why whenever you have LVF, you dare touch the fluid, you never touch the fluid. Whenever you have a right ventricular failure, in that setting, you can give a fluid, not a problem. But again, I'm starting fluids only based on the JVP. That's why I told you fluid optimization rather than giving a fluid. Suppose if you give a JVP of less than 12, which means the fluid is not that good, then in that setting, I can give a fluid. Suppose if JVP is more than 12, then you can give fluid, no problem. Here, reperfusion attempted or not? Definitely it's attempted, I'll tell you. So this is only optimization before reperfusion. Suppose if the patient is still there, you're not able to improve, then you have to give again interim measures. Here the interim measure that is typically preferred is IABP because that's a left ventricular assist device kind of a thing, impeller. So you cannot use it here. But here IABP can be well used once again. But the benefit of IABP is more with left ventricular failure compared to the right ventricular failure. Again, if you ask the best modality, it's going to be reperfusion only. And of course, I'm going to prefer a PPCA in a right ventricular failure. So whenever there is a chance, always do a PPCA. Lysis is not really a good method of doing reperfusion in the first place. So this is all about RV failure. So why I'm telling is because the blocks are very common in right ventricular failure. Always try to find out the block and try to synchronize them. For example, you can do pacing also to synchronize them properly. If they're because of dyssynchrony also, they might have a kind of poor contraction. So if you synchronize them better, then they will do well. So try to synchronize if the AV blocks are very severe. Then apart from that, you can have mechanical complications. So what are the mechanical complications that that can happen in the setting of a STEMI? So one is going to be your VSD, or I can write as VS or ventricular septal rupture. Then you have papillary muscle dysfunction. Papillary muscle dysfunction, which can result in something called a MR, mitral regurgitation. Then finally, we have something called a free wall rupture. These are 3 mechanical complications. And before going that, what are things that you should avoid in the setting of a right ventricular failure? I mean, if you have listened carefully, then you should be able to answer what are things that you should avoid in a right ventricular failure. Yes, whatever that reduces the preload has to be avoided. Beta blockers should be avoided in any failure or shock. It doesn't mean right ventricular, left ventricular. Beta blockers are contraindicated in any kind of failure or shock. So leave that. I'm talking about specifically right ventricular failure, what you should avoid. You should avoid anything that reduces the preload. That's really important. Apart from that, I mean, nitrates are correct. Nitrates are going to reduce the preload. Diuretics we tend to avoid in right ventricular failure. Okay, then conservative fluid strategy should not be given in the setting of right ventricular failure unless and until your JVP is very high. Because in left ventricular failure, we don't touch the fluids. We tend to give as little fluids as possible. But in right ventricular failure, we'll give a completely different treatment. Anything that reduces the preload, you should never use in a right ventricular failure. But as far as the left ventricular failure is concerned, the first thing we actually do is to reduce the preload by the mechanism which I've explained already. VSR is ventricular septal rupture. It is like a VSD only, but here we call it as a rupture, just like that. Okay. So what will be the clinical features? Is there any difference between right ventricular and left ventricular failure? Can you divide them clinically? Right ventricular failure versus left ventricular failure. How will you divide clinically? Both will have dyspnea, but I'm talking about clinical difference between right ventricular failure and left ventricular failure. Remember, both can have hypotension, both can have elevated JVP. Yes, more importantly, left ventricular failure usually will have crepitations. Right ventricular failure generally does not tend to have crepitations. Apart from that, LV failure, what else? If you do a PCWP, have you ever heard of something called a PCWP? Pulmonary capillary wedge pressure, it will be more than 18, usually in the setting of a LV failure. JVP is variable, but it can be normal or elevated. That doesn't give a big clue. But as far as right ventricular failure is concerned, usually there will be no crepitations. If it's isolated right ventricular failure, there should not be any crepitations. And at the same time, the PCWP will be less than 16, which means the left atrial pressure will be less than 16. That is pulmonary capillary wedge pressure. And of course, JVP will be increased. And additionally, if they give a heart failure with Kussmaul sign. So can you tell what do you mean by Kussmaul sign? Naveen is telling ankle edema. Naveen, we are talking about an acute right ventricular failure here. We're not talking about a chronic right ventricular failure. Kussmaul sign. Yes, generally JVP tends to decrease with inspiration. But in Kussmaul sign, JVP tends to increase with inspiration. The paradoxical increase in inspiration. That's what we refer to as Kussmaul sign. But remember the fact that Kussmaul sign, even though it is described as a very important sign for the constrictive pericarditis, but it can happen in right ventricular infarction also. One of the important areas where you can get Kussmaul sign is right ventricular infarction. In fact, even some people can get pulsus paradoxicus also. But we'll be discussing that subsequently. So this is how you clinically differentiate right ventricular failure versus a left ventricular failure. So what about the mechanical complications, that is free wall rupture, VSD, and all these things. So as far as VSD is concerned, so VSR, ventricular septal rupture is concerned, it's going to be extremely common with the anterior wall myocardial infarction, especially if the apex is affected. And it can happen sometimes in inferior wall myocardial infarction also, if it's involving the basal septum. Clear? Basal septal VSD. So if it's inferior wall, it will be a basal VSD. If it's a anterior wall MA related myocardial infarction, then it's going to be a apical kind of a VSD. Mostly, it can be diagnosed easily by clinical grounds, not a big deal at all, because you're going to easily find out that typical harsh kind of a pansystolic murmur or a holosystolic murmur. So clinical features, you're going to have that PSM, that is always referred as a holosystolic murmur, which will be very harsh. And most of the times it's very easy to find out that it's not very difficult to miss out in the first place. And the VSD is a condition which is going to result in something called a biventricular failure. So any patient presenting with a feature of a biventricular failure, having a pansystolic murmur after getting STEMI, usually it is common in elderly patients with a very large MI. If that is the case, then you can think about a ventricular septal rupture. Treatment, whatever may be the mechanical complication, the first thing is to inform the cardiothoracic surgery. You have to send the patient to CTVS. We call CTVS because it's a cardiothoracic vascular surgery. VSD, VSR, both are same. In the setting of an acute MI, because it's happening acquired, we call it as a ventricular septal rupture. That's all. Previously, it was intact. So defect is something that is there congenitally. So then in that case, we call defect. Rupture is something that happened as an acquired basis after the myocardial infarction. Plus medical management is also important. Medical management, because there is a left ventricular failure, you have to reduce the preload here. So by giving some vasodilators and probably diuretic agents, plus at the same time they might be needing inotropes, plus or minus they might be needing IABP also. So preload reduction is very important, and always refer the patient to CTVS as soon as possible. Then we have the free wall rupture. It's a very estimated complication and very under-recognized complication, this free wall rupture. So there are some risk factors for free wall rupture. So whenever the patient is having thrombolysis as a treatment, especially if it's done late thrombolysis is having a risk of developing free wall rupture. And very large myocardial infarction, female patients, presence of hypertension, and at the same time, if the patient has used NSAIDs in the last 1 week before getting myocardial infarction. So all these are risk factors for developing free wall rupture, because NSAIDs will impair the healing process. That is the reason why after getting a myocardial infarction, NSAIDs are absolutely contraindicated for the first 1 week. You should never give NSAIDs because it will impair the healing process and they can accelerate the development of free wall rupture. And how they are present, because once the ventricle ruptures, typically they'll come with either a pulsar electrical activity or asystole, because it will cause a rapid tamponade-like effect. So they'll go for a PA and an asystole. And that PA and asystole, as I told you, it's because of the development of rapid tamponade, cardiac tamponade, and they're going to die for sure if you don't treat them on time. And treatment is highly controversial. I'm going to refer to surgery. Any mechanical complication, as I told you, immediately call the surgeon or refer to surgery. But in the meanwhile, you can try other techniques like doing a pericardiocentesis to remove the blood that is surrounding the myocardium to relieve the heart from going for tamponade effect. And you can give IV fluids, inotropes. All these things can be tried. You're asking what is PEA? Can anyone expand PEA for him? Yesterday, I think we have discussed so much about PEA. INR98. What is PEA? We have discussed last night, isn't it? What do you mean by PEA? Yes. Pulseless electrical activity. Then we have papillary muscle rupture, papillary muscle dysfunction or papillary muscle rupture causing a mitral regurgitation. This is the third mechanical complication. So of course, the papillary muscle that goes for rupture is often the posteromedial papillary muscle that often goes for rupture because it has a single blood supply from the posterior descending artery, PDA. Anterolateral papillary muscle has a dual blood supply from both LCX and RCA. So because it's having a dual blood supply, sorry, not RCA, it is LAD. LCX and the LAD, both are actually supplying the anterolateral papillary muscle. Usually that will not go into a trouble. It's the posteromedial papillary muscle that often goes for rupture because it's having a single supply in the form of PDA. Usually papillary muscle rupture is very, very common in the setting of an inferior posterior MI, especially when the LCX is affected, especially when the left side circulation is there or left dominant circulation is there. In that setting, the risk of developing papillary muscle rupture and MR is extremely common. So most common with inferior posterior MI usually happens to rupture the posteromedial papillary muscle because it's going to have a single blood supply in the form of posterior descending artery alone. Then how the patient will present. Clinical features. Clinical features will be that of a left ventricular failure because it is the LV volume overload that's going to cause the trouble. And at the same time, you're going to have a new murmur that will develop. But remember, this murmur will be a little different from what you see in the chronic MR. In chronic MR, you will see that characteristic PSM, holosystolic murmur. But as far as the acute MR is concerned, you might not get the, I mean, I'm not telling always, you might get, but usually you do not get a pansystolic murmur because the LV compliance will be very poor. So why that is important? Because whenever the MR jet comes into the left atrium should dilate adequately to fill the left atrium, and the entire LV jet to come and fill the left atrium should be very compliant. The left atrium is not compliant and it's not expanding properly in acute stages. So the LV jet that comes will fill the atrium immediately, and the atrium is failing to expand further because of poor compliance in the acute stages. So the jet may not happen after the early part of the systole. So you might even end up with the early systolic murmur or early to mid systolic murmur. You might not get that characteristic pansystolic murmur as what you see in the chronic mitral regurgitation that you see for your exam cases. So that's one point that you need to know. And again, they're going to develop LV failure very rapidly. And if you take the JVP, not JVP, if you do the PCWP curve, PCWP, you will see one important wave. So to understand this, I will ask you about JVP. In JVP, what is the wave that you will see prominently in tricuspid regurgitation? In tricuspid regurgitation, what is the JVP wave that is seen commonly? What is this wave that is enlarged in tricuspid regurgitation? Characteristically, it is the V wave that is enlarged. Same thing in PCWP, you will see a very large V wave. Which means what is PCWP? PCWP is nothing but a measure of left atrial pressure. The left atrial pressure that you have is what indirectly measured as a pulmonary capillary wedge pressure through the right heart catheterization. So that's why in PCWP also you're going to see a large V wave. There is a MR. If you are having an TR, then you'll have a large V wave in the JVP. But if you have a large V wave in the PCWP, that indicates a mitral regurgitation, MR. And treatment, once again, I'm going to refer the patient to surgical field only because always mechanical complication means send the patient to surgery. That's the first take-home point. Plus or minus, I can give the treatment in the form of reducing the preload because it's a left ventricular failure, like nitrates and diuretics and all this stuff. Plus or minus, if I need, I can take the patient for IABP also. IABP is a standard for any cardiac failure, to be precise, but it's more effective for left ventricular failure than the right ventricular failure. So these are the management options for 3 mechanical complications, that is ventricular septal rupture, free wall rupture, and papillary muscle rupture. So now you know what are the complications of STEMI. You have LV failure or a mechanical complication. So basically you can split the cardiogenic shock into, after a STEMI, cardiogenic shock post STEMI. This is a nutshell summary I'm giving, into pump failure versus mechanical complications. Pump failure can be LV pump failure or an RV pump failure. Mechanical complications can be VSR, MR, that is due to papillary muscle rupture, or it can be free wall rupture. So this is a nutshell. So this is the details of the cardiogenic shock that are going to get in patients with a STEMI. So is there any scoring system that can quantify quantify the risk of death in patients with cardiac failure in MI? Yes, you have something called a KILIP score. This is a very common question in exam. What do you mean by KILIP score? You have 4 classes: KILIP class 1, class 2, class 3, class 4. What do you mean by class 1 KILIP? First class. Because this should be known by the finalist itself, isn't it? Class 1 is no pulmonary edema, evidence by no S3 and no crepitations. Okay. Class 2. You have pulmonary congestion, but not pulmonary edema. S3 and crepitations will be there, but only in the base that suggests that the patient is having pulmonary congestion, not edema. Then class 3, you can have S3 and you have crepitations, but at least more than 50% of the lung fills. So this is the definition of a pulmonary edema basically. Crepitations covering more than 50% of the lung fills means the patient is having a pulmonary edema. Then class 4 is cardiogenic shock. Usually, the mortality will decrease in this direction. Mortality will increase in this direction. Clear? So mortality will increase in this direction, which means we know that 1 is going to have the least mortality and 4 is going to have the highest mortality. So this is KILIP score, very important for exams. Yes. And apart from that, you have many other scoring systems are there based on hemodynamic profile, but that is not really important for our understanding. So then we can have arrhythmia. So first complication we discussed about the STEMI, that is ST elevation myocardial infarction. Most common site of free wall rupture is inferior base of the heart. That is where the free wall rupture will be usually. Rupture will happen very commonly at the base. Base means at the inferior wall of the heart. That's what we have found. So that's where the heart is going to rupture very commonly. Forgot to mention the TIMI flow grid. Where? Why you really need that TIMI flow grid? I don't think it's really important. If there is time, we'll discuss after that. And again, that will create a more confusion. Cardiology itself is going in a different level in the sense like one topic that is very difficult to explain to a undergrad is the cardiology. Because undergrads, as far as I know, especially the final year and the pre-final year, think that MR, AR, MS and AS are the cardiology. That's all. If they understand these 4 things, cardiology is over. But the problem is, I don't know whether still everyone has that belief or not. Because ultimately, whenever they think about cardiology, that's what they know and that's what they want. But it is too much, like that contributes. If you take the standard textbooks like Braunwald, or if you take any other standard textbook, this 4 valvular heart disease will contribute to only 4 pages of the 2000 page book. That's all. And which means you are learning only 4 out of 2000 in your entire final year. That's what you're going to do. And whenever we talk about PCI, cath, or whenever you talk about these kind of STEMI complications, they will be like, what the hell is talking and why should we really talk about all these things? Do we really need this? I mean, Abhiram is saying due to pandemic, these 4 also we don't know. That's a good one. But anyways, I'm planning, I told you, I'm planning to conduct 2.0. In that, we'll see how beautiful the clinical cardiology is. Actually, that needs a separate kind of a discussion. You cannot really finish off the entire cardiology, like especially the valvular heart disease and all in the particular section. This section is contributed to the NEET PG students. So that is the reason why I want to really take the topics that are oriented towards the NEET PG exam. 2.0, I think I'm planning in November, depending on we are conducting for final year only, specifically 2.0. But the problem is we need the numbers, like this setup itself, is costing us a lot. In the sense like still I'm not a person who's having a lot of investment from other areas, and whatever we do right now, we are trying to give as much as quality as possible, but this setup itself needs some kind of number of students who has to attend. So if the number of students are good, then I'll be conducting 2.0 for sure. Yeah, live class only, definitely live class. What else we can do? Okay, so now we have told about the cardiogenic shock also. Then let us move on to the other complications. So the most important other complication is arrhythmias. Arrhythmias can happen in and out in a post MI setting. And arrhythmias itself, we have different groups of arrhythmias can happen at different times of myocardial infarction. The first thing that can happen is heart blocks. Heart blocks, which can happen in myocardial infarction. Remember, heart blocks can happen under two settings. One, it can happen at proximal RCA infarction. Proximal RCA, or heart blocks can happen in the setting of a proximal LAD occlusion also. So proximal RCA occlusions causing heart block is much, much commoner than proximal LAD causing heart blocks. It is not that common. It is less common. So what are the types of heart blocks that you can get with proximal RCA infractions? You can get a sinus bradycardia. This is supposed to be the most common because we know that RCA supplies the sinus node also. Second, it can cause AV blocks also. In the sense, what are the types of AV blocks? They can produce first degree heart block, they can produce Mobitz 1 block, and they can produce complete heart block. But getting a Mobitz type 2 is extremely rare with proximal RCA infarct. So why Mobitz type 2 is very rare? If somebody wants to answer that question, because Mobitz type 2 is basically considered as a infranodal block. Most often Mobitz type 2 will be infranodal in nature. Even though we call it AV block, but the block usually in Mobitz 2 will be infranodal in nature. That's why Mobitz 2 is little difficult to manage also. I'll come back to that. So proximal LADs related heart blocks are less common, but if they happen, they can produce sinus bradycardia. They can produce Mobitz 2, which can rapidly degenerate to complete heart block, which means the Mobitz type 2 block is more common with proximal LAD lesion most often. And remember, most of the times Mobitz 2 will rapidly degenerate to complete heart block. Most of the times it will rapidly degenerate to complete heart block. It will not stay as Mobitz 2 itself. I think this ECG we have seen. Anyone who remembers this ECG, that Mobitz 2 which has degenerated to complete heart block? Anyone remembering this ECG which I discussed yesterday? Yes, we have discussed that. Mobitz type 2 usually degenerates to complete heart block very rapidly. That's why Mobitz type 2 and type 1 itself has a lot of difference. Suppose if you really want to know Mobitz 1 versus Mobitz type 2, Mobitz 1, the defect is in the AV node, but in Mobitz type 2, usually the defect is infranodal. Mobitz 1 generally tends to be benign, but Mobitz 2 generally tends to be harmful, and they rapidly degenerate to complete heart block. Usually the patient with Mobitz 1 will be stable. Many of the times the patient with Mobitz 2 will be unstable. And many times it responds with conservative management itself. You need pacing for Mobitz 2 most of the times, especially if it happens in the setting of a STEMI. Usually it needs a pacing most of the times. Most of the time it needs a pacing. So because many of the times Mobitz 2 associated with the STEMI, proximal LAD is infranodal, usually associated with the white QRS. Because it's nodal, most of the times it will be associated with a narrow QRS. We are talking about the escape rhythm. The escape will be usually narrow QRS only, unless until there's a de novo bundle branch block. So usually the escape rhythm in the setting of Mobitz 2 will be having a wide QRS in this setting. So most of the times you need pacing for Mobitz 2. Clear? Which means conservative means I'm not talking about no pacing usually required. No pacing generally required for Mobitz type 1. That's what I'm talking about. Anyways, so that's the reason why proximal LAD tends to be more dangerous. Remember, proximal RCA infections causing blocks generally tend to be little hemodynamically stable, whereas proximal LAD occlusions causing bradycardias and blocks generally tends to be unstable, which means they will be hemodynamically unstable as well. Then, of course, here you just need reperfusion, nothing more. That's enough to treat a proximal RCA occlusion. That itself will clear the blocks. But of course, here you need reperfusion, all right, but you will be needing pacing as well. So usually you will need pacing, otherwise it will not respond. Proximal lady related bradycardias, most of the times it will be resistant to your treatment. Reperfusion also will not help much in the setting of proximal lady occlusions. So these are the heart blocks that you're going to get, which you have to be a little clear about that. Then you can get some other arrhythmias also. Like for example, you can get ventricular arrhythmias. What are the ventricular arrhythmias that you can get? So of course you can get ventricular tachycardia and ventricular fibrillation. Remember, torsades is extremely rare because being a structural lesion, very commonly it will produce monomorphic VT only. Polymorphic VT can happen, but not so common. So usually it will produce monomorphic VT only. So of course we know how to treat this kind of VT and VF. So remember, if you want to use the drugs, of course you will shock it. That's different. That's one of the very important method. But if you want to use some drugs, prefer lignocaine as a first choice, or you can prefer amiodarone also as a first choice, depending on your understanding about the disease. Lignocaine may be good if the patient is little stable and you think that they won't degenerate, then you can give a less effective drug, lignocaine, to avoid the side effects of amiodarone. If you think that the patient is going to go for rapid degeneration into other arrhythmias and they're going to die and they're unconscious, and if you want to prefer a drug, prefer amiodarone, which is having a higher success rate. Once again, I always feel like in medicine, there is nothing like treatment of choice or a drug of choice. It is always about the rational choice, like in what situation, what drug is better. Always assess that plus minus speed of action and the side effects and the patient profile, hemodynamic stability, so many things you have to assess and you have to think about in a fraction of a second, and you have to go for a particular drug. So I believe ligno can be given first, no problem, unless until the patient is completely unstable, where you go for shock and amiodarone. That's what I really believe it is correct. Okay, anyway, drugs you're going to give either lignocaine or amiodarone. So once the VT has reverted, you know that the VT is going to come back. I mean, because it's a structural lesion. What drug you can give as a prophylaxis to avoid this VT and VF from coming back? I told you this multiple times. You should be able to answer by now. Beta blockers. You can try increasing the beta blocker dose. So once you have reverted, you can try increasing the beta blocker dose, because beta blockers are protective against ventricular arrhythmias, especially in the setting of a Stemi, ST elevation myocardial infarction. Remember, suppose if the VT and VF persists for more than 48 hours, if it persists for more than 48 hours, this is really important. You have to plan for an ICD, that is implantable cardioverter defibrillator. That's really, 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 really important. Very important point. This is an AIMS question. If it persists beyond 48 hours, you have to plan for an ICD implantation. If it's less than 48 hours, no problem. It is one of the important indications for ICD. But VT, VF persisting for, I mean, not VF, usually VT only. VF, if it persists, the patient will be in the heaven already. So we're talking about a VT that is persisting beyond 48 hours. So I can write here, is an indication for an implantable cardioverter defibrillator. I didn't tell you one more point. Suppose if the patient is having maybe heart failure plus EF less than 40 post-Stemi, this becomes an indication for one drug. What is that drug? Anyone who tells definitely must be practicing, or he must be a PG. Who's that? Who's going to tell? Heart failure plus EF less than 40 post-Stemi. One drug has a good coverage here. No, definitely not digoxin. No, not thiazide. ACE inhibitors, yes, I can agree. Beta blockers, no. I mean, you are going to routinely give beta blockers, so that doesn't make. They specifically mention EF less than 40, heart failure post-Stemi. Spironolactone or eplerenone, mineralocorticoid receptor antagonist or aldosterone antagonist. This is a very important point. Spironolactone has a good evidence. One of the important indications for spironolactone, heart failure and EF less than 40 post ST elevation myocardial infarction, you can start with spironolactone in that setting. Okay, we have discussed about ventricular arrhythmias, and one more ventricular arrhythmia is there, that is called the AVR, accelerated idioventricular rhythm. So I told you this is like a VT only, but the heart rate will be less than 100, unlike a VT. At the same time, it's a very benign rhythm. In the sense, it will be reperfusion arrhythmia after doing a PCI or after giving a thrombolysis. This arrhythmia is extremely common. It's a reperfusion arrhythmia. and usually it does not require any treatment. That's why AVR is also referred to as slow VT, but it's better to avoid this kind of terminology. It's better to call AVR, that is accelerated idioventricular rhythm. It's like a slow VT. As I told you, the same VT kind of morphology will be there, but it will happen at a rate of less than 100 per minute. It's a benign rhythm, typical reperfusion arrhythmia. Generally, don't need any treatment. If you think you want to terminate it, you can try giving atropine, because atropine increases the SA node rate. Once the SA node rate increases to 120 or 130, because you gave atropine, because this rhythm is happening little slow at 80 or 70, or by overdrive suppression, the sinus node impulse can suppress this AVR. So atropine can be used sometimes for AVR if you really feel so, but apart from that, nothing needed to be done. It will revert spontaneously. That's AVR, that is accelerated idioventricular rhythm. Then you can get other arrhythmias also, like for example, you can get atrial fibrillation. Some atrial arrhythmias like atrial fibrillation. In fact, if you ask about of the entire arrhythmias, I feel atrial fibrillation is supposed to be the most common, because almost 15% of the patients will develop atrial fibrillation among the tachyarrhythmias. If you ask bradyarrhythmias, anything can happen, but among the tachyarrhythmias, AF is supposed to be extremely common compared to other ventricular arrhythmias. Of course, you treat like a standard AF only, but here very commonly we use digoxin also, because dig has a very good role here, because the patient will be in heart failure. Whenever heart failure with atrial fibrillation, you are going to give digitalis. Or plus or minus, you can use beta blockers and amiodarone also. So these are optional, but one of the better drugs in this situation is digitalis if you have a atrial fibrillation, because that has a very good role here, because that is an inotropic agent. If there is a heart failure, that will resolve that also, and it's an AV nodal blocker also, though, so that it reduces the rate of atrial fibrillation also. And at the same time, I'm going to give anticoagulation. Not a big deal when you are dealing with the patient with the STEMI, because already they will be under anticoagulation, which means you are just going to continue the heparin that you are already giving to the patient. That's all, no problem. Heart failure, why beta blocker? Because you are going to optimize the heart failure, right? So heart failure is not going to be continuous. That's why it's not like X or Y or Z. It's like gray zone most of the time. So we have to give beta blockers even in heart failure. And when you discuss the treatment of, chronic heart failure we are treating, you know what is the first line drug in chronic heart failure? ACE inhibitor. Can anyone tell what is the second line treatment in heart failure? So once you have optimization with ACE inhibitors is poor, then what is the second line treatment in chronic heart failure? Beta blockers. Then why you are answering beta blockers here? Patient is having heart failure, right? So it depends on what kind of situation you are dealing with. If it's an acute pulmonary edema, that is also kind of heart failure only. So there, I don't use beta blocker. Suppose once optimization, the patient goes for a kind of a chronic heart failure, then still I can use beta blocker. Beta blockers become one of the important treatments for chronic heart failure. So it's all about context where you use. So that's how our understanding also changed. If you take in 1984, there was a famous paper in Lancet, I think, which told beta blockers kill the patient. So don't use beta blockers. That's the time beta blockers came. Then in 1996, they told beta blockers are demons in patient with heart failure. These are the, the topics that came really. In 2003, studies told beta blockers are marginally effective in reducing the arrhythmias. And in 2010, beta blockers and its superiority in heart failure, in chronic heart failure. In 2016, a review article came telling beta blockers are the gold standard. Yes, this is what happened over a period of time. So, from demon to gold standard, that's the nature of beta blockers. So that has happened, consistently in medicine. So which means you think one drug is bad today, the same drug can become a gold standard tomorrow. So beta blockers are the best example for that. Beta blockers are absolutely contraindicated once upon a time in heart failure. Now we use extremely commonly in heart failure. Once again, it's about the context where you use beta blocker. In acute heart failure, if I'm decompensated, pulmonary edema is there, I'm of course not going to give a negative inotropic agent like beta blocker. But if for chronic heart failure optimization, definitely I use beta blockers because they are extremely beneficial. They are going to reduce the myocardial oxygen demand. They are going to reduce the workload on the heart. and they're very good in fact. So to reduce the size of the infarct, for all these things, beta blockers are extremely good. So if acute heart failure, don't give acute pulmonary edema, but all the other cases you can still consider giving beta blockers, not a problem at all. Then once we have discussed about the arrhythmias, then we need to discuss on other complications of myocardial infarction. Like for example, these are miscellaneous complications you can think about. So we can write a complication, we can write clinical features, and of course we can tell the treatment of that particular complication also. In that, the most important complication I need you to know is the ventricular aneurysm. As far as the clinical feature is concerned, it happens only after a STEMI. It never happens after an end STEMI or an unstable angina. It's a pure complication of a STEMI because that only causes transmural infarction. So usually it is like outpouching from the left ventricle, which can be clearly seen in the echocardiogram. So if you really take an echocardiogram, you will see a non-contractile outpouching of the left ventricular myocardium, and that will have a broad base. That's very, very important, broad neck. So because it's a true aneurysm, that will have a broad neck. That word is the most important, broad neck, in the echocardiogram. And more importantly, in the ECG, you know what the change you will be encountering, that is persistent ST elevation even beyond 3 weeks from the time of treatment of a STEMI. If the patient is asymptomatic, think of an aneurysm, do an echo, broad neck, outpouching, non-contractile segment of the myocardium. It confirmed it is a ventricular aneurysm only. And of course, you might be needing surgery, but you can treat percutaneously also. Either you need a surgery or you can do a percutaneous repair also. No problem, depending on the situation. And next is pseudoaneurysm. Pseudoaneurysm is really important again because this is a emergency. Because pseudoaneurysm also happens post-STEMI only. It usually does not happen after the end STEMI or an unstable angina. If you do an echocardiogram in this setting, they will show a narrow neck, not a not a broad neck. So this is the most important difference between them, because you need to really differentiate between a ventricular true aneurysm and a ventricular pseudoaneurysm, which will have a broad neck and narrow neck respectively. So apart from that, this is dangerous. This is not good because here it's a true aneurysm. All right, so ventricle is just outpouched like this, and you're seeing a broad base. But whereas in the setting of a pseudoaneurysm, what happens is the myocardium has ruptured basically. The myocardium has ruptured and it's getting sealed by the contractile portions of the myocardium. And there will be a thrombus here that is sealing this part that is ruptured. And there is a pericardium that is also sealing this part that is getting ruptured. So there's a pericardium also. So if you think this is a pericardium, thrombus, and there is a rupture of the myocardium. So that is the reason why it is having a narrow neck. So which means it's dangerous, because once this leaks out, because it's the thrombus and the pericardium that is sealing the defect, once it leaks, it's gone. You're going to result in rapid tamponade, pulseless arterial activity, asystole, and death. So that is why this is something like a emergency. That's why you have to immediately take the patient for surgery, or you can even do a percutaneous repair also. Clear? You can go for a percutaneous repair also. But remember, this can be done a little slowly, not a problem, but this is emergency. This is a surgical as well as a medical emergency. You should not really leave this for a long time, because it's going to rupture at one point. So it's really important to understand the difference between a ventricular true aneurysm and a pseudoaneurysm that happens post myocardial infarction. Number 3, you get a left ventricular thrombus. That is because of the sudden dilatation of the left ventricle because of the infarction. And that non-contractile segment, because the blood goes for stasis there, they'll go for thrombus. Very common. 1/3 of the patients post-STEMI will develop some form of left ventricular thrombus. So it's better to treat. So usually diagnosis, you don't have any clinical features. They can produce thromboembolism. Still, it's like the same like atrial fibrillation. They can produce stroke also. But you're going to diagnose through echo also. Where echo, you can clearly see the echogenic thrombus. The best view, as far as I know, is the apical 4-chambered view. That's what I prefer to do. When we do an ICU, the apical 4-chambered view, clearly, like the heart will be like this many times, the 4-chambered view, isn't it? The heart will be something like this. So this will be the RV, LV, RA, LA. So many times we'll see the thrombus here, the tip. So apical thrombus is extremely common most of the time. So that's where you see it's an echogenic structure in the echocardiogram. It's easy to find out. So echo is one of the very good events and very good techniques in this, finding out the left ventricular thrombus. And of course, you're going to anticoagulate as a treatment. So how long you have to anticoagulate? Standard, 3 to 6 months. The same for pulmonary embolism also. 3 to 6 months you have to anticoagulate. Then you can get early pericarditis. There are two things. One is called early pericarditis and second is late pericarditis. Early pericarditis typically happens within 1 week after a STEMI. Remember, again, this is an absolute complication of a STEMI only. It will not happen after a end STEMI or unstable angina. Incidence is quite common also. Almost 1 in 5 patients, that is 20% of the patients, may develop some form of early pericarditis. The reason is very simple. So because STEMI causes something called a transmural infarction, and there will be a surrounding pericardium like this. And once the inflammatory cells come into this area, they can spill their inflammatory content and they can produce a surrounding pericarditis in that area. So it will be a very local and focal pericarditis, but still it can happen exclusively after STEMI because that only produces a transmural infarction. This early pericarditis is not called as Dressler syndrome. That's the most important point. It's not Dressler syndrome. It's a early pericarditis related to post-myocardial infarction, especially ST elevation myocardial infarction. And of course, you will be diagnosing based on clinical expertise only because chest pain will be there, rub may be there. Because it's a very localized pericarditis, it's very difficult to pick up. So you can do an ECG. You might see typical changes of pericarditis. You might get in exams also. But anyways, the most important point here is it will happen within a week after a STEMI. That's the most important point. Treatment, simple. You're going to just increase the dose of aspirin. You know, you're going to give only 75 milligrams per day. Here you can use up to 650 milligrams 4 times a day. You can try giving colchicine, no problem. But please remember the fact there are two other things that you need to know. One is NSAIDs should not be used in this setting because I told you in the first week, that's why I told you that point specifically. In the first week, NSAIDs are absolutely contraindicated because they impair healing and they can increase the risk of free wall rupture. So don't use NSAIDs. That's the first thing, because in other pericarditis, apart from early MI pericarditis, the first line treatment itself is NSAIDs only. So don't start there. Second, reduce the anticoagulation. Reduce anticoagulation if possible. Why you have to reduce anticoagulation? Because you can develop something called a tamponade in that. Why? Because if you give more anticoagulation, there can be bleeding in the inflamed area. Here the inflamed area is pericardium. So because it can bleed into the pericardium, because of anticoagulation, they can result in bloody effusion and kind of a tamponade. So don't do that. Reduce anticoagulation and give only increasing dose of aspirin, but don't use NSAIDs. Second one, we have late pericarditis. Late pericarditis is what we refer to as something called Dressler syndrome. It's autoimmune in nature, so it's going to have some peculiar features. It's rare compared to early pericarditis. If you compare the pericarditis, early pericarditis is common, late pericarditis is relatively rare. You get only 1 to 2% overall incidence, late pericarditis in our population. Usually it can happen anywhere around 2 to 8 weeks post myocardial infarction, post STEMI or post end STEMI unstable angina. So I cannot write post STEMI. It can happen after end STEMI unstable angina also sometimes. So post myocardial infarction, it can happen. But the key is less than 1 week or more than 1 week. If it's more than 1 week, I'll go for a Dressler syndrome. If the pericarditis happens within a week, I'll go for a early pericarditis. So remember, the process here that is happening is a kind of an autoimmune process. So which means you'll have multisystemic involvement, not only pericarditis, so which means the patient will have pericarditis, patient will have pleuritis, patient will have pericardial effusions, patient will also have pleural effusion, patient may have left lower lobe consolidation, patient may have arthritis. So because it's autoimmune nature, all this can be associated. Not all will be seen all the time, but some of the features may be seen. But the timing is the most important. You don't diagnose based on all these things which I mentioned, but the timing is going to give the diagnosis in the exam. And here, once again, my primary treatment will be increasing aspirin plus or minus. Here I can use NSAIDs because it happens a little late, not within the first week. So, okay, I can use NSAIDs, not a problem. But both these, if you see, steroids, I will not be using. Both these kind of pericarditis, I will not be really using the steroids. Steroids are unnecessary. In very, very unremitting cases, then you can go for use of steroids. But apart from that, it's easy to treat in general. So you not really give steroids in this perspective. I think this will summarize the contraindication. This will tell you the complete contraindication list as far as the STEMI is concerned. And STEMI also has a similar complication. STEMI also has a similar complication, but you'll have lesser complications compared to that of a STEMI. STEMI has the highest in-hospital complications. Last two, CF, what is that? Which one? Which clinical feature you're talking about? This is left lower lobe consolidation and arthritis. I'm talking about arthritis there. Left lower lobe consolidation and arthritis. So do RV regional wall motion abnormality resolves after PCA? It depends how fast you do a PCA. If you do PCA very early and reperfuse very early, there is a possibility. You can reduce the regional wall motion abnormality. Possible. Can steroids cause myocardial thinning and rupture? Yes, correct actually. NSAIDs as well as steroids both will reduce the healing. Especially if it's given in the first week, it's going to be more dangerous. After the first week, not a big problem. Once the area is healed, it's not an issue. But in the first week, both are dangerous. They can cause thinning and rupture because the healing process will be impaired. That is the reason. So cool. I think we have completed the STEMI and the end-STEMI process also. Post-MI stabilization is not important for you. Post-MI stabilization is not really important for you, where you do the stress test. You're going to start with statins. I don't think really that is important. So let us move on and discuss on the chronic stable angina. That's better. I mean, unnecessarily wasting time on post-MI therapy or not. Alex is asking if reperfusion is successful, will QA appear in ECG? There are a lot of evidences. Suppose if reperfusion is successful and if you did very early reperfusion, QAs can even disappear and the patient may have a normal ECG back. If you do very early reperfusion, that's why in STEMI reperfusion is supposed to be very important. And Braunwald told one famous statement. Can anyone tell what is that statement? It's one of the very, very famous statements. I mean, people who are very much interested in cardiology will be knowing about that. What Braunwald said. Eugene Braunwald is a very big name in cardiology, isn't it? Riju is telling time is gold. No, actually it told something else. Time is muscle. That's the idea. I think whether you told it knowingly or unknowingly, time is muscle. So that's what it told. So the more time you waste, more muscle you lose. The less time you waste, less muscle you lose. That's all. So that's very, very good statement. In any cardiology lecture you go, especially STEMI and end-STEMI is concerned, any ACS lecture, if you attend, the first line they will give is time is muscle. That's told by Eugene Braunwald only. The more time you waste, more muscle you're going to lose. That's all. So early reperfusion is very, very good, especially in the setting of a STEMI. And sometimes the QAs that are formed already also tends to disappear. So due to a lot of process, don't worry about that. So don't argue with me now right now telling it's already dead. How can it get better? No. A lot of things are there in that. So it can even get better. That has been proven in a lot of trials. So Q waves may or may not appear. It depends on how fast you do. That's the answer to Alex's question. Yeah, all ACA lectures starts and ends with the same lines. Yes, time is muscle. Yeah, that's really, really important. Okay. Now we are moving on to something called chronic stable angina. mean, not chronic stable angina. It's important to know how will you approach a patient who's having a chronic chest pain. Chronic chest pain. Whenever the patient is having a chronic chest pain, I am going to assess the risk of having a CAD. Remember, in cardiology, it's always about the pre-test probability. So here, we are starting with something called a pre-test probability of CAD. So whether it is low or whether it is intermediate or whether it is high. This is a very simplified algorithm what I'm going to give. If the pretest probability is low, I can write here, I think. The pretest probability is low, then usually I don't do any treatment at all. No treatment or no evaluation is generally required. But even though for the purpose of risk stratification, I can do exercise stress test. EST can be tried for the purpose of risk stratification alone. Apart from that, I don't really need anything. If you are really thinking about low probability, because low probability means the probability of having a coronary artery disease in this patient is less than 15%. That is low probability. Second is intermediate probability, where the risk of having a coronary artery disease is 15 to 85%. Third is a high probability of having a CAD, where the risk of having a coronary artery disease is more than 85%. So whenever you think about a high probability of coronary artery disease, it's best to go for a coronary angiogram, or alternatively, you can go for non-invasive testing also. Non-invasive testing also in certain selected patients. But once the non-invasive testing is showing a high-risk disease, or if the patient is having a severe chest pain, in all these settings, it's better always to go for a coronary angiogram. Remember, you can do either a coronary angiogram or a non-invasive testing. But if the patient is having a severe chest pain, or if the patient is having a high risk, when you do a non-invasive testing, still it is better to go and do a coronary angiogram in this setting. So what you have to remember is high probability patients, it's better always to do a coronary angiogram straight away. No need to just keep on wasting time with non-invasive testing. Unless and until you don't have any specific indications, you can go for non-invasive testing. No issues. Then what about this intermediate probability patients? Intermediate probability patients, these are the confusing group of patients, because you don't know whether you just need to send the patient home or you not need to go for a coronary angiogram. You really have no idea. But the guidelines clearly tell the non-invasive testing is best done for intermediate probability patients. In exam, multiple times they've asked this question, especially in institute exams and all. If they ask you where non-invasive testing is best done, your answer must be unequivocally intermediate probability CAD patients only. So you're talking about, yes, Pranav, I was about to tell that. Pranav asked like, what exactly is pretest probability? So remember, before doing any test, there is something called pretest probability. That's based on something called the Bayes theorem. I don't know whether how many of you have studied this in statistics. Bayes theorem states that the post-test probability of having a positive result from a particular test is directly proportional to the pre-test probability of having a positive result post the test. It might be a little confusing, but which means we are predicting what is the best example. For example, I am a very healthy man. I don't have any comorbidities. I don't have any bad habits like smoking, and no other risk factors are there. Suddenly, like I'm getting some kind of a chest pain, which happened for maybe 3-4 minutes. I got a chest pain and that resolved. I didn't do anything. Just it got resolved. Just think and tell. So my pretest probability of having a MI at that point of time is low or high. So I'm telling that I had a MI for 4 minutes. You think it's correct or it's incorrect? It's low risk or high risk. I'm having a low probability of MI or a high probability of MI. Low probability of MI. So if I am going to be taken for a coronary angiogram, will you think it is sensible or insensible? Of course, I'll feel it's insensible, because that's logical. That's what Bayes theorem is exactly all about. So the pre-test probability, you have to see to do a particular test so that you will get something out of it. So suppose if my grandfather is there, like who is 65 years of age, he had a typical ischemic pain. For half an hour, he had an ischemic pain. and ECG showed some changes, but it got reverted again. He's a chronic smoker, taking cholesterol medications for a long time. He's a hypertensive also. In that setting, I'm taking the patient to my grandfather to a cardiologist, and he's telling, no, it's likely to be simple only. No need of any evaluation, go home. That is insensible again. Because there, my risk of having some significant coronary artery disease in him is extremely high. So this is what we refer to as something called a pretest probability. So you have to know before doing a test. So for every test, you should assess the pretest probability, whether that test is sensible or not, whether you'll be able to get something out of that test. So it's not like I should not be going for a coronary angiogram. Even I can go for a coronary angiogram. But what I'm going to get, the result beforehand itself that is going to be normal, then why you want to do the test? If you know the pretest probability is extremely high, many people do argue, then why you want to do a coronary angiogram? Because my grandfather, you can argue that still is going to have a coronary artery disease. You know that he's going to have a coronary artery disease. Then why still you want to do a coronary angiogram knowingly that he's going to have a disease? You can argue like that also. But the idea is not like that. Doing a coronary angiogram means we don't only see the coronary artery disease. We are going to do something in the same sitting. If it's a significant disease, then I can do stenting, or I can do other options like if this is a triple vessel disease, I can convince the patient to go for a coronary artery bypass grafting. Riju is asking, write the Bayes theorem. No, I won't write. You just check it and you type it here tomorrow. Let everyone knows. That is the homework for you, man. Okay. So that's all it is. So how will you assess the pretest probability? Based on the chronic chest pain, how are you going to assess that pretest probability is what we need to know. So let me take, it's a simple one. So first let us take a patient who is young without risk factors. Young without risk factors and having a atypical chest pain, and patient who is old and having a risk factor, having a typical chest pain. So here what exactly meant by risk factors means I'm talking about, let me write here. Here exactly I mean by risk factors is the hypertension, diabetes, dyslipidemia. And you can consider smoking also to an extent. And what do you mean by old here? Old means males more than 40 years, females more than 60 years. And what do you mean by young? Males less than 40 years and females less than 60 years. This is the definition of young according to this. I mean, many people can be thinking that males become old by 40 years according to cardiological perspective, but females are still young up to 60 years. From cardiological perspective only, you know what I mean. So which means if the patient has risk factors, I mean, patient is young and not having risk factors and having atypical chest pain. I mean, you know what you mean by atypical chest pain. We have just now discussed the 3 out of 3 category. 3 out of 3 is typical, 2 out of 3 is atypical, 1 out of 3 is basically non-cardiac chest pain. So if the patient is young, no risk factors, having atypical chest pain, means this is a perfect example of a low risk group, I mean low pretest probability group. Old patient with risk factors having a typical chest pain is a high probability group. Any cross combinations, for example, old patient with risk factors getting a atypical chest pain, or a young patient without risk factors getting a typical chest pain, are all coming under intermediate probability group. This is intermediate pretest probability. So now you know what you mean by low pretest probability, high pretest probability, and intermediate pretest probability. Everything is based on the clinical understanding only. Do you get this, what I'm trying to tell? How will you assess the pretest probability in a chronic chest pain? If you tell yes, then we'll move on. Yes, you got it. So this is the pretest probability. So once you have known the pretest probability, now I know what I'm going to do. So if it's a low pretest probability, then usually I don't want to do anything. I just, I mean, if needed, I can do exist tests just for stratification. And high pretest probability means better to go for a coronary angiogram. Still, you can try non-invasive investigation also, but if the non-invasive investigation shows high risk in these patients, then you have to go for a coronary angiogram. Suppose what if the non-invasive investigations are showing low risk? What will you do here? If they are showing something called a low risk, what will you do here? What will you do here? Which means in this condition, I'll just continue with the medical management. So whatever medical treatment I want to give, like statins or aspirin, I'll be continuing with that. And the anginal pain treatment, I'll be starting. That's the medical treatment I'm talking about. So non-invasive, I told you the best people, young person with baseline ECG changes. We'll come back to that. Wait. The best area where you can go for non-invasive investigation is the intermediate pretest probability group only. These are the best area where you can go for non-invasive testing. So there are many non-invasive testing are there, because especially when you are considering a final years, a lot of final years are attending this class, it's going to be really difficult to explain to them. But I can tell in a nutshell. So what are the non-invasive testing that is available? It depends. For example, the first question I'm going to ask is whether the patient is able to walk or not. That's the first question. If yes, you have to use always treadmill based tests only, because treadmill, if they ask you overall what is the best kind of test, I will always prefer treadmill based test only, because treadmill based test can tell one additional thing. They can tell the functional capacity of the patient. You can do functional assessment. What is, how much the patient is deconditioned, how much the patient can walk. That gives a vital information. So functional capacity of the patient can be assessed only with treadmill based testing only. So I'll always prefer treadmill based test. Suppose the patient is not able to walk, then in this situation, I can use a pharmacological stress test. Pharmacological stress testing in this particular condition. Otherwise, I don't really want a pharmacologist. I'll always go for a treadmill based test only. Then next step is to see whether is there any baseline ECG changes. Baseline ECG changes or baseline ECG fluctuations are there. The most important is the left bundle branch block, which produces so much of changes in the baseline of the ECG. We have seen already in the ECG discussion. So if the patient has left bundle branch block, in this setting, if there are significant baseline ECG changes that will affect the interpretation of our ECG, then in that setting, it's better to go for a treadmill imaging. If no, you can go for a treadmill ECG, treadmill electrocardiogram. So this is the commonest thing that we do in our practice, but everyone knows, everyone would have known the treadmill ECG. But if they ask you among these two, which will you prefer, treadmill imaging versus treadmill ECG, what you will prefer? I have not given anything. I'm not given the baseline ECG changes. Patient is able to walk. And if you want to prefer treadmill imaging versus treadmill ECG, what is the investigation that you will prefer? Of course, the most important thing that you need to know is I'll prefer a treadmill imaging only. The reason is because treadmill ECG is having a lot of inter-observer variation. Observer-related bias is very high, and it's all about how you pick up these findings, because some findings may look benign to some cardiologists, some finding may look problematic to some cardiologists. So it's all about observer bias is there. And it's neither sensitive nor specific, which means the sensitivity of treadmill ECG and the specificity of treadmill ECG is quite poor. That's why many countries like United Kingdom, in the NHS guidelines and Scotland-related guidelines like SIGN guidelines, have removed the treadmill ECG from the routine evaluation in their guidelines. But still, in low-resource countries like India, you can still prefer doing a treadmill ECG. But anyway, this is the algorithm that I wanted you to tell. Okay. So once I know the pharmacological stress test, I'm using a pharmacological stress, then I can go for imaging technique. Some kind of imaging is important. What imaging you will prefer, again, depends. So what is the basis of all this? First, let us see the basis. So what is the basis of all these things, what you're discussing? So whenever you do a non-invasive testing, the idea is to give a kind of a stress to the heart. And once you are given a stress, you're going to image the heart. So this is what we refer to as stress imaging protocol. So you give a stress and you image. That's what you're going to do. You want to find out what the heart is doing at the time of stress. The stress that you can give either can be a physical stress. For example, that's what you do in a treadmill. You ask the patient to walk. That's a physical stress. Heart has to pump hard. Or you can do a pharmacological stress. What are the examples of pharmacological stress that you can give? For example, you can give drugs like dipyridamole, or you can give adenosine, or you can give something called a regadenoson. Latest one. So these are the drugs that are going to cause something called a pharmacological stress. So both are very similar. Treadmill or whatever, your dipyridamole, adenosine, or regadenoson are going to produce a similar effect on the heart as far as the heart is concerned. But you'll not be knowing the functional capacity with pharmacological stress. Yes, you do have dobutamine also. That's a form of stress, but I don't really prefer dobutamine stress echoes, but you can still use dobutamine, no problem. That's also a type of stress only. But I don't really like giving, I mean, it's going to have a lot of, again, low sensitivity and low specificity kind of an issue. But this is excellent, adenosine-based test. So exercise and this adenosine dipyridinol are going to have a similar effect. We know that. So we often have the microcirculation. That's what we're going to assess. So this is the aorta. This is the coronary vessels. So for example, let us assume this is a left circumflex or a left coronary artery, whatever it is. So ultimately, this epicardial vessel is going to divide into this kind of microcirculation. We also know that. And whenever the patient goes for exercise, what really happens is your microcirculation goes for significant dilatation. There'll be a significant dilatation of the microcirculation. Why your microcirculation has to dilate? Because they has to supply this extra blood into the cardiac muscle. So that's why the microcirculation dilates. But if the patient is having coronary artery disease, for example, is having a plaque here, when you're doing an exercise, this microcirculation, even though if it dilates, it will not be able to provide sufficient amount of blood. Even though this microcirculation dilates, you will not be able to provide sufficient amount of blood because of the obstruction that is happening over here. So that's what happens. So, I mean, you might be thinking that microcirculation is dilating, but still because the flow is limited here, they cannot fill this microcirculation adequately. That's the problem. In a normal time, even in the presence of significant occlusion, they might be able to fill this microcirculation under normal conditions because now the caliber of the vessels is basically very small. During exercise, because they become very big, and this obstruction and limited flow may not be able to feed all this microcirculation, which is tremendously dilated. So now they will go for ischemia, and now they'll go for chest pain. So that is the purpose of doing an exercise. And now this ischemic myocardium will show some ECG changes and imaging abnormalities. And this is the basis of doing an exercise-based stress test. The same thing is going to happen if you're going to give an adenosine, for example. If you're going to give an adenosine, what's going to happen? Adenosine is going to, it's a microcirculatory vasodilator, which means adenosine preferably dilates the microcirculation. It's going to mimic the same kind of scenario like that of what you do in the exercise. So that is why adenosine-based stress tests are also the same like that of exercise-based stress tests, but still exercise has one important advantage that apart from the microcirculatory dilatation, it will tell you the functional capacity of the patient. So that's a very, very vital thing according to me. That's a very important piece of information. So that's why we need all these things. So that's what we are planning to do here in the first place. So which means now you know what you mean by stress and what you mean by imaging. So stress can be given in the form of either a physical stress like treadmill or a pharmacological stress like dipyridinol, adenosine, or even a dobutamine is fine because it pushes the heart to extra. Last drug is regadenoson. R-E-G-A-D-E-N-O-S-O-N. Regadenoson. Okay, so that's what is going to happen. So now imaging can be anything. So what is the imaging? I'm not imaging, or you can do an ECG. So you prefer some kind of imaging because you have created a stress on the myocardium. You have produced some sort of stress and you created some sort of an ischemia to the myocardium, ischemic kind of an environment to the myocardium. Now how the myocardium responds to that ischemia. That is the information that we want. We just don't want to create a stress. We don't want that response from the myocardium, that we wanted to image it, capture it, and find out whether it's a high risk feature or a low risk feature. So that can be captured during an ECG. That's why we do a treadmill ECG, or it can be captured with the help of an imaging. So this imaging can be done by multiple methods. What are the imaging techniques that we have? You can use an echocardiogram for imaging, which means there is something called a treadmill echocardiogram, where you can ask the patient to run in a treadmill. After that, you can immediately image the patient. So that's called a treadmill echocardiogram if you use a treadmill kind. So or you can use a treadmill nuclear imaging, or you can even go nuclear if you want to image. So there are a lot of types of nuclear imaging which we'll discuss. So which means the stress, what you're going to decide is up to you and again up to the patient, or you can choose the imaging modality also. So combine both. So you can use a treadmill ECG or a treadmill echocardiogram, or a treadmill nuclear imaging also. Or on the other hand, you can use a pharmacological stress testing like dobutamine stress echo, or you can use a pharmacological nuclear imaging as well. I think you must be able to get that. Are you understanding or not? So what do you mean by stress and what do you mean by imaging? What is the thing that you give in stress? And I mean, giving that stress, you have to capture that response from the myocardium through some imaging technique. Understanding or not? So otherwise, it will be very difficult when I used to tell what is mean by SPECT, PET, all these traces. Understood? Yes. Question comes on best drug. What is the, I mean, I don't know what is the best drug, man, for pharmacological testing. I don't know. This kind of questions can be asked only by undergraduates and students who are preparing for post PG. I mean, for PG exam. Always asking the best, worst, first, last. Okay. Deepika is asking what is Bruce protocol. We have not even touched this, like stress testing yet, and you wanted to know the Bruce protocol. It's one of the treadmill protocols. That's all. Okay. In India, we use adenosine now. If you want to know this thing, India, we use adenosine. So nuclear imaging. So Deepika is asking what do you mean by nuclear imaging? Nuclear imaging has a lot of types are there. For example, you can use something called a SPECT, or you can use something called a PET. So there are a lot of traces that you can use in SPECT and PET. So for example, you have a thallium-201, that's thallium SPECT. Then you can have technetium-based SPECT traces also are there. For example, as far as the perfusion is concerned, technetium-based SPECT, you can use something called Stemi, or you can use tetraphosphine. These are technetium-based traces that you can use, and PET-based traces, you can use fluorodeoxyglucose, FDG PET, where you have F14 fluorodeoxyglucose, or you can use ammonia PET, that is N13 ammonia, or you can use rubidium-82, rubidium-based PET. So these are the traces that we generally use. Tetrophosmin, TETROFOSMIN, tetrophosmin. Sestami was parathyroid. Sestami is a tracer you can use for many conditions, not only for parathyroid. It can be used for assessing the myocardial perfusion also. Now, if you take this nuclear traces and you wanted to really check stress thallium, thallium-201. What is the stress thallium? So you want to image. So there are some traces that are useful for perfusion. There are some traces that are useful for assessing viability of the myocardium. But as far as the chronic chest pain is concerned, or a chronic cardiac pain is concerned, the perfusion is the most important. Viability is secondary. That is important in some other scenarios where we assess the need for reperfusion in a chronic heart failure patient. That's different. But this perfusion becomes little important, especially in a chronic chest pain patient. So for example, you have thallium-201 traces, which can assess the perfusion as well as the viability. Then you have technetium-99 traces, which can assess the perfusion alone, but they are very poor in assessing the viability. And we have the PET traces, which can assess the perfusion as well as the viability. So the biggest advantage of thallium is you can assess both perfusion as well as viability in the same sitting, in the sense like in one tracer, just one tracer, which is low cost also. And you can assess the perfusion as well as the viability in thallium SPECT. But the problem is the image quality is a little poor. You get a low resolution image. It's not that great. And at the same time, there are a lot of other problems in image reconstruction and all. So that's why thallium is not very commonly used nowadays. Because it is of low perfusion. So how can it assess a single tracer? Thallium-201 is a single tracer. It can assess the test perfusion and viability both in the like same sitting, because it has one important property called redistribution. It has some important property called redistribution. That's why it can assess perfusion viability in the same sitting. And at the same time, why it has important property of redistribution? Because it's considered to be a potassium analog, which means it's taken actively by the sodium potassium ATPase. If they ask you who concentrates the thallium into the cell, it is sodium potassium ATPase. So that is the reason why it can assess the viability also to a great extent, because if the viability is not there, sodium potassium ATPase will not work, isn't it? That's somehow it can assess the viability also. Single tracer. Now you can ask, sir, what is the big deal? Even PET is also assessing perfusion as well as viability. But remember, even though it assesses perfusion viability both, the PET traces, you need different traces. You need different traces. Same tracer cannot assess perfusion viability both. For example, FDG is supposed to be the best tracer for assessing the viability, that fluorodeoxyglucose. And as far as the perfusion is concerned, you can use either this N13 ammonia traces or this rubidium related traces. And if among the two, if they ask you the better one, it's going to be the ammonia. Ammonia is going to be a better tracer compared to that. So what is the advantage? Relative advantages, they will have a better image resolution. That's an advantage. But the biggest disadvantage is the cost. It's going to be heavily costly, too costly, the PET-based traces, because it needs cyclotron to generate them. Very, very costly. Only if the country is very wealthy, you can do PET-based testing. But apart from that, it's very costly because you need a cyclotron to produce these traces. But coming to the technetium traces. Technetium traces are extremely good in assessing perfusion, but they are bad in assessing the viability. So what are the traces that are available for testing the perfusion? We know we have two traces, that is Stemi and tetraphosphamine. Both can assess the perfusion, but they are very poor in testing the viability. And they're usually trapped by a process called metabolic trapping, and they're concentrated in the mitochondria most of the time. And one big advantage of technetium-based traces, it's again better resolution, better image quality and better resolution. So currently, like the world is going towards technetium-based tracer analysis only. And at the same time, one of the important advantages, it is of low cost. But the disadvantage as far as technetium is concerned is it cannot test viability. Cannot test viability of the myocardium. So that's a very important drawback of the technetium. But still, as far as the chronic chest pain is concerned, we need only the perfusion analysis. Viability is not that important in this setting. Okay. So what are the half-life of these drugs? That also becomes an advantage. Remember, the thallium traces have a very long half-life, which means it's around 72 hours. So which means almost 3 days. And the imaging takes a long time. There is something called in and out time. Sometimes thallium-based imaging, the in to out time, maybe even 2 days or 3 days. So you need so much of repeat imaging with thallium. So, and again, the half-life is very high, more radiation exposure. And at the same time, you need a lot of time to image these patients. You might need like 3 to 4 hours. You have to image once. Then again, you go back and come again after 24 hours. Then you might need a second injection again. Again, you re-image again. So many problems are there with thallium where the patient may not be compliant. It takes a long time to get the image done. But half-life of this technetium traces are only 6 hours. Very small. And at the same time, half-life of this PET traces are again very low, depending on the tracer that you're going to use. For example, this rubidium-based traces half-life is only 75 seconds. And FDG-based traces half-life is only 110 minutes. And ammonia-based traces half-life is only 10 minutes. Which means they are having half-life in minutes, very low half-life. Which means the in to out time will be very fast. For example, for technetium-based traces and PET-based traces, the in to out time, the patient comes in, gets the image and goes back. The time is only 3 hours or 4 hours max. So the patient goes in the morning, afternoon he gets the report. So what is the basis of this test? What is the idea behind this test? So which means it's faster. That's the reason why currently we are moving away from thallium and we are moving towards technetium-based traces and PET-based traces. Suppose to reduce the cost, what they currently do is for perfusion, you can do technetium-based traces, and for viability, you can do a PET-based tracer analysis. Riju is telling that I read somewhere that elimination of technetium takes approximately 1 million years. I think, I don't know whether elimination is different from half-life or not, but as far as I know, half-life is only 6 hours. I will read it and I'll come back to you tomorrow. So what really happens? Okay. So for currently, the technetium-based traces are the ones that are preferred for testing for perfusion scans. And for viability, we use PET scan. This kind of a hybrid kind of a thing. So technetium for perfusion and PET for viability. This approach will have a better image quality. At the same time, you can considerably reduce the cost also. Instead of using PET for both, which is going to have a very high cost, you're going to really do this and get a better image resolution at the same time, cut the cost down as much as possible. So this is the idea behind this kind of nuclear testing. Or you can do something called a dobutamine stress echo also. Even that is fine. So where we use echo is typically used for dobutamine. We don't use for nuclear testing. Some advocate for nuclear testing. I mean for pharmacological stress testing also you can use echo, but better to use along with dobutamine. That's called dobutamine stress echo. So which means to do any non-invasive testing, you need a stress and you need an imaging technique. So based on this only we are going to do. So now you will be able to answer, isn't it? So what do you mean by a treadmill imaging? What do you do by a treadmill ECG? Here the stress is treadmill, imaging can be anything. Here the stress is treadmill, imaging is ECG. Here the stress is pharmacological, imaging is usually nuclear. So who is asking? Something is asking. Alex is asking, sir, the pre-test probability criteria which we discussed earlier was Duke staging. I think is confusing with something called a Duke's treadmill score. DTS is there. There is something called a Duke's treadmill score. That's what you're trying to confuse with. That's completely different. I don't think there is something called Duke's staging. Anyways, fine. So now you know what you're trying to do. So what is the whole idea of doing this treadmill? I mean, this kind of stress testing. What is the whole idea of doing this kind of stress testing? Because you are going to assess the risk of the patient. Risk stratification. Based on this, because how the myocardium responds to your stress is what you are getting. Oh, Riju is telling Duke staging is for colon cancer. That many people know. He's asking about the cardiology perspective. So Vijay is telling inducible risk. Of course, yes. So we are finding about is the patient is how the myocardium is responding to that particular inducible ischemia that you're going to look for. So based on that, I can tell whether the patient is having a high risk or whether the patient is having a low risk. If the patient is having a high risk, then in that setting, I'll prefer doing a coronary angiogram straight away. If the patient is having a low risk, then in that setting, I will just continue with the medical management in that setting. So medical treatment. We'll discuss what do you mean by medical treatment. Now, of course, we are doing coronary angiogram at a lot of settings. So we did a coronary angiogram here. So I'll put a shape here. So we did a coronary angiogram here. And we did a coronary angiogram here also. Okay. So we did a coronary angiogram here. And we did a coronary angiogram here also, depending on the non-invasive testing. That's why I told you, even here, if you see a non-invasive testing, once it comes as a high risk, then I'm going to do a coronary angiogram only. So at any point, if you do a coronary angiogram, the idea is to find out what is the disease. Based on the coronary angiogram, I can tell whether the patient is having a significant CAD, coronary artery disease, or they are having a non-significant CAD. So when will you tell that the patient is having significant CAD? If the stenosis is more than or equal to 70%, or if the stenosis is more than or equal to 50%, in the presence of some functional flow limitation like FFR less than 0.8. So FFR is assessed through a different means through the coronary angiogram itself. So if anything more than 70%, I generally take it as significant. Or if the stenosis is more than 50% plus FFR is less than, that's fractional flow reserve less than 0.8, then in that setting, I can consider it to be a significant flow limiting ischemia. But people who don't want to know about this FFR, you can just think like if the patient is having severe LVH or if the patient is having severe anemia. So even in that setting, 50% also becomes really, really significant. So non-significant, anything less than 70% becomes non-significant CAD. Suppose if I'm encountering a significant CAD and significant functional limitation is also there, in this particular setting, I'll be thinking about going for a cath versus a CABG, PCA versus CABG. So how will you decide? Severe anemia cutoff. From cardiological perspective, you can take 7. 7 is the universal cutoff for many severe anemias. If you're asking for exams, I would tell 7. So when you have a significant coronary artery disease, you can go for either a PCI or either you can go for a cabbage. For PCI, in the sense like this is an elective PCI, this is not a emergency PCI, not a rescue, not a primary, not a pharmacoinvasive. So this is a different kind of a PCI. We're doing an elective PCI for a chronic chest pain here. Or you can go for a cabbage. As far as PCI is concerned, usual indications are uncomplicated single vessel disease or a double vessel disease. So this is going to be the usual indication. But remember, there are a lot of other entities like syntax coronal, which you have to really take into perspective, but that is really not needed for you. So syntax score more than 22, syntax score less than 22, where you have to decide versus PCA versus CABG again. I don't think really that's needed for you. But anyways, as far as cabbage is concerned, the usual indications that are undergrad level or for exams you should know is, one is a triple vessel disease. Second is left mainstem disease, LMCA disease, or probably a very proximal LAD disease. I mean, don't confuse by the word very, I just wanted to substantiate that it's a proximal LAD disease. So if you have a proximal LAD disease, triple vessel disease or LMCA disease, then your cabbage may be a choice. But remember, the first two has the strongest indication, triple vessel disease and LMCA, and the indication will become strong. They'll become more strong if the patient has LV dysfunction, that is low ejection fraction, and at the same time if the patient has diabetes mellitus. If the patient has diabetes and if the patient has LV dysfunction, the indications will become even more stronger. So single vessel disease, DVD means double vessel disease. 2 vessels are involved. That is double vessel disease. Clear? Understood. So these are the indications for cabbage versus a PCA. And as far as PCA is concerned, we have many different types of PCA are there, but we are talking about the stent related PCA. So one, you can use either a bare metal stent or either you can use a drug-eluting stent. Of course, what we prefer is the drug-eluting stent only. We don't really prefer the bare metal stent that much. LMCA. LMCA means left main coronary artery. I think you're attending only today. We have been discussing LMCA for the last 2 days. BMS, bare metal stent, and probably drug-eluting stent. There are 2 types of stents. And as a beginner, if you have not yet understood anything about the stent, so this probably will give you an idea. So what really happens? Suppose if you take, this is the coronary vessel, and you have a plaque here. You have a significant plaque here. You have a significant plaque. So you have a flow limitation. So what you're going to do with stenting in the first place is you, for example, if there is a thrombus, what you do is you extract this thrombus first using a catheter. Once you have extracted this thrombus, you insert a guide wire kind of sort of a thing, and you move the balloon into that area, and are going to expand the balloon. Once you have expanded the balloon, now the situation becomes like this. Now the plaque will become going outside the vessel like this. You are displacing the plaque outside because now in the catheter you have dilated the balloon. Because you have dilated the balloon, now the plaque goes outside. That's called balloon angioplasty. Previously, this is the only thing that you have been doing. But right now what we do is, once you have displaced the plaque like this, we are going to deploy a stent there. We are going to deploy a self-expanding metal stent there, and that will self-deploy, and we're going to come out. So this is the basic idea how the stent really works. And of course, now the flow is restored. You are going to get a reperfusion. But what they encountered with this kind of bare metal stents is, because these stents are foreign material at the same time, they're going to irritate the endothelium. Middle class have been saving for this balloon their entire life. Okay. That's a good one. Actually, Riju only told this, which means you're talking about the cost. Middle class have been saving for this balloon their entire life. No, the cost of the balloons have come down drastically, man, nowadays. Okay. But I will tell, but I will tell one more thing. If middle class uses one more balloon, they can save more for their life. I think you can get what I mean. Okay, fine. So let us move back to the coronary angiogram and stent. So as far as the stent is concerned, now you know that the flow is restored now. So because the flow is restored, the patient will get free of symptoms. But one problem is, remember the fact that the like the stent will not be like what I have drawn. It will be like something different. I don't know. I don't have the image. This is called like there will be some gaps. That's called a stent strut is there. So stent will be like this. And you can Google it and see, because I don't have the image. The stent will be having gaps in between like this. They will be having like a mesh kind of a thing. So this is how the stent will be, but they will be in a tubular structure. So you can understand it's like a metal part only. So you can understand what I mean. That's how the stent is going to be. So after some time, one more thing that should happen is, this is a vessel, you know that. And from this area, slowly, the endothelium will start developing, growing inside. This is called as neoendothelialization. This is what we refer to as stent endothelialization. I mean, you can remember like a mesh, correct? So I don't know how to tell. You can remember like a mesh, and over time the endothelium will grow over from that sides and all, from that small openings. They will grow and they will complete the endothelialization. This process is what we refer to as something called a endothelialization, and it takes some time. And this is what we want actually. Why we want endothelialization is because we don't want this. Yeah, the Jew is telling like a hernia mesh. Okay, fine, cool. You can think like that also. So it's more rigid, by the way. So we call it as something called endothelialization. This endothelialization is important because the stent is something like a foreign material which can induce a thrombus by itself. So once the endothelialization happens, your thrombus formation is not there, because now it is covered by a natural substance. That is endothelium. So once the endothelialization happens, now your risk of thrombus formation will be extremely less. So it will not be a problem. But what happens over time is, sometimes the endothelialization may be too great. Endothelialization may be too great that it can become something like this. So because that foreign material irritates the endothelium so much that now endothelium has proliferated too much, and this is like too much endothelialization and too much, that's called neointimal proliferation. So too much of neointimal proliferation is there. And what has happened now? Can anyone tell? So now the flow will be limited once again after a period of time. So this is what we refer to as a restenosis. So to avoid this problem, they used something called a drug-eluting stent. So what do you mean by drug-eluting stent? So it's similar to what we have seen. So in drug-eluting stent, we are going to use some cytotoxic drugs. That's what we're going to use. So which means, let us assume the same kind of stent I'm going to use in drug-eluting stent also. Shit. Same kind of stent, but I'm coating this stent with some drugs, like cytotoxic drugs. What are the drugs I'm going to use? Initially it started with paclitaxel to start with. It's an anti-cancer drug, we know that. Then they moved on to second generation with tacrolimus, and then to third generation with sirolimus. Now they are using everolimus, and in United States now research is going on for zatorolimus coated stents also. But in India, sirolimus coated stents are very, very popular. Clear? So remember, paclitaxel is an anti-cancer drug, it's a taxane. And tacrolimus is basically a calcineurin inhibitor. All the other drugs that we're using currently are basically mTOR inhibitors. So why we are using these drugs? This is actually to prevent the over-endothelialization. Over-endothelialization, or you should not write over-endothelialization, I can write as to reduce the neointimal proliferation. That is why we are using this anti-cancer drugs, neointimal proliferation, because these drugs are basically inhibitors of cell proliferation. So what you are basically doing is you are slowing down the endothelization so that the endothelization happens slower and it happens at a very reduced pace. So that's what we are trying to do. So which means definitely usage of drug-eluting stent will reduce the risk of in-stent thrombosis. Reduce the risk of restenosis for sure. Reduce the risk of restenosis. But the problem is they significantly increase the time for endothelization. Remember, our endothelization is also important. So they're going to significantly increase the time for complete endothelization. Remember, in bare metal stent, the endothelization happens much faster. But whereas in drug-eluting stents, the time for endothelization is going to be extremely high and it's going to take a long time for endothelization to happen. So if it takes a long time for the endothelization to happen, then definitely this drug-eluting stent is going to have a higher risk of developing in-stent thrombosis compared to that of the bare metal stent, which is having a lesser risk of in-stent thrombosis. So if they ask you about in-stent thrombosis risk, it's actually higher with drug-eluting stent compared to the bare metal stent. So since bare metal stents, your endothelization is faster, the usual DAPT is advocated only for 1 month. You need not give more than that. But on the other hand, as far as the drug-eluting stent is concerned, because your endothelization and complete endothelization is tremendously delayed, you have to give DAPT for at least 1 year minimum. So that means aspirin and clopidogrel or any other P2Y12 inhibitor. So after that, what you will do, you have to continue aspirin for lifelong. And of course, after this, again, you have to continue aspirin for lifelong. So many students do ask me why here DAPT for 1 month, why here DAPT for 1 year. That is because drug-eluting stents are going to significantly impair the endothelization. Because in an attempt to reduce the restenosis, but that's okay. But still, you must be very clear that your DAPT should be there for at least 1 year because the time for endothelization will be extremely long. So till that time, you have to cover up with the dual antiplatelet regimen. So this is the basic concept of the stents. I think, are you able to understand? So why you are giving the stents and how the stents work and why DAPT is different for all these things? Clear. So at the same time, one more important thing to notice, suppose if you are having acute coronary syndrome, if you are using DAPT for an acute coronary syndrome, in that setting, your DAPT should be for at least 1 year, that is 12 months, irrespective of the treatment used. I'm not telling irrespective of the stent type, that is irrespective of the treatment itself, which means whether you use a thrombolysis or whether you don't use a thrombolysis, whether you use PCI or whether you don't use a PCI, or whether you use a BMS or whether you use a DS, all those things doesn't matter. If you are giving DAPT for the purpose of acute coronary syndrome, their 1 year of DAPT is mandatory. Especially, guidelines are suggesting when you are going for a stenting like this, bare metal or drug-eluting stent, the DAPT that you use should always include powerful drugs like ticagrelor, Brilinta. That's what they're telling. A powerful drug like ticagrelor should be preferred ahead of clopidogrel, which can produce more risk of in-stent thrombosis compared to ticagrelor. That's why currently we prefer ticagrelor, especially if the patient has been stented after a Stemi. That's one point. So in-stent thrombosis, it's not instant thrombosis. Naveen, if you're worrying about that, it's actually in-stent thrombosis. Maybe you're typed wrongly, but I'm correcting if you're wrong. In-stent thrombosis, how will you dilate on top of a mesh? So suppose if you're developing an in-stent thrombosis, what I'm going to do is I'm not going to directly dilate there. So first I'll put a catheter to suck the thrombus out. So I'll take the thrombus out, then only I'm going to dilate. So I'm not going to just like that dilate. I'll suck the thrombus first using apparatus. Then only I'm going to use a balloon dilated. Then only I'm going to put a stent there. Fine. So what are the types of cabbage available? There are many different types of cabbage available, that is coronary artery bypass grafting available. For example, you can use, they will usually in exam, they will ask you about the grafts only. Grafts can be basically divided into venous grafts, which are basically low potency grafts. Then you have arterial grafts. Arterial are low potency as well as high potency are there. Venous grafts, typically we use the SVG grafts. SVG means saphenous vein grafts. Saphenous vein grafts. And as far as arterial grafts are concerned, we can use either a radial artery graft or probably we can use a LEMA, that is called left internal mammary artery. Clear? Otherwise referred to as LETA also, that is left internal thoracic artery. Both are same only. LEMA or LETA, both are same. So LEMA grafts. Among all these grafts, the graft with highest patency is supposed to be the LEMA graft only. And SVG and radial artery grafts are going to have a very less patency compared to other grafts. SVG and radial artery are very less patency, but LEMA is going to have very high patency compared to all the other grafts. One important thing that you have to note basically. So that is the reason why LEMA grafts, it's not like preferred graft and all. Suppose the patient is having multivessel disease, LEMA is usually used to anastomose high risk vessels like left antidescending artery. Whenever you use, LAD is a very high risk disease because LAD already I told you it is called as a widow maker. Why they are calling it as a widow maker? Because it supplies the left ventricle, and if it is gone, everything is gone. Even right ventricle will fail. So that is the reason why LEMA typically we prefer for anastomosing with left antidescending. SVG grafts are probably radial artery. Radial artery we don't use really, but SVG grafts generally is used for probably for right coronary artery and left circumflex. For this purpose, we can use SVG grafts. Even if the patient is having only RCA involvement, still I'm going to use only SVG graft because there if LEMA is only limited length. If I use LEMA there itself, then in the future if the patient gets LAD involvement, then I will not be having any good graft to bridge the LEMA. So always most of the times, as far as LEMA is concerned, you preserve for usage for left antidescending artery. It's a high risk artery. But SVG grafts you can use for low risk vessels like right circumflex and right coronary artery and left circumflex. These are the type of grafts that are available. Even though SVG and radial artery are having low patency, we use under certain circumstances. It's not like, because whenever I tell something to the postgraduate, like PG preparing student or NEET PG aspirant, if I tell LEMA is having high patency, immediately in the note it will translate as LEMA is the graft of choice for all the coronary artery bypass grafting. So instantly it will change into something like that. So I want to tell it's always about the choice that we make rather than it's like the only one that you're going to use for your entire life. So it should not be like that. Anyways, so I think now you will be understanding the management of a chronic chest pain. But only one thing which I have not yet discussed is the medical part of the treatment which you need to give. So I'll discuss very shortly now. So what is the medical management? As far as the medical management is concerned for STEMI, so for chronic chest pain, number one is going to be the risk reduction. So I need to reduce the future risk. I need to reduce the risk reduction. Cardiovascular mortality should be reduced. For that, I can use either aspirin and statin most of the times together. Remember, only these drugs can reduce the mortality. Remaining whatever drugs I'm going to tell now are not going to reduce the mortality. So number one, I have to reduce the symptoms of the patient. Aspirin, statins won't reduce the symptoms. They will only reduce the death due to myocardial infarction in the future. Because of that, I will be in a situation where I have to reduce the symptoms of the patient also. To reduce the symptoms, I have a variety of drugs. For example, the usual choice of drugs will be beta blockers. Excellent drugs that can reduce the chest pain to a great extent. One of the first choice drugs. Now, second choice drugs will be non-dihydropyridine calcium channel blockers. I can just use calcium channel blockers. But what kind of calcium channel blockers you will use? You can use both. You can use either a dihydropyridine calcium channel blockers. These are basically dipins like nifedipine, amlodipine, and all this stuff. Or I can use a non-dihydropyridine calcium channel blockers, like for example, verapamil or diltiazem. Typically, we prefer verapamil for this purpose. So, but one point that you have to notice, since beta blockers And non-dihydropyridine calcium channel blockers are very powerful AV nodal blockers. We saw yesterday, A, B, C, D. Beta blockers and non-dihydropyridine calcium channel blockers like verapamil-diltiazem are very powerful AV nodal blockers. This combination is better to avoid. More than avoid, I can say a part of caution. And even though many cardiologists use this combination very commonly, but you have to be having a little bit of caution. For exam purpose, you can think it's better to avoid them because they can cause fatal AV blocks. If you want to use a CCB, use a DIPIN, which is also very good vasodilator. And now you are moving on to the Vinith is asking, my dad is on DAPT for more than a year. Any specific reason? You have to ask your cardiologist, but it's better. If he's not got any event in between, you can stop the DAPT and you can give only a single agent. No problem. No need to be on DAPT for a long time, which unnecessarily increase the risk of bleeding. So beta blockers and calcium channel blockers are the choices. Now you are going on to the next choice. So, if the patient's chest pain is still not controlled, you have added beta blockers, you added calcium channel blockers, the patient's chest pain is still not controlled. Now in this setting, it's better to add a third drug, obviously. So, but remember, before adding a third drug, it's always make sure, but whether coronary angiogram is done already or not. Remember, if not done, do it. Post for CAG, if not done. Because 2 drugs you have given already, beta blockers and CCB, still the patient's pain is not resolving. Even if you think that the patient is coming under a low risk, not responding to this couple of drugs still make them a high risk. So it's better to do a coronary angiogram in this setting if not already done. But meanwhile, till the angiogram is done, it might take for a long time. Meanwhile, you can add a third drug. Third drug can be, many drugs are there. For example, you can add ivabradine, which is basically a funny current inhibitor. And it has to be given, in a sinus rhythm, especially if the heart rate is more than 70, we discussed yesterday. Then you can use a drug called ranolazine, which is a very, very good drug, which is a late sodium current inhibitor. Ranolazine. Then we have nicorandil, which is basically ATP sensitive potassium channel opener. It has a drug with dual action. Dual action in the sense it opens up the ATP sensitive potassium channels, and at the same time it is a vasodilator also, direct vasodilator also. So remember, because of the nitrate like action. Why it is a vasodilator? Because it has got nitrate like action. Because that's the name nicorandil, because it has a N stands for nitrate like action. Nicorandil. So ranolazine is a late sodium current inhibitor. That's how it works. And all these drugs, whatever, like vasodilators, or you can use nitrates also. Nitrates, especially for chronic conditions, nitrate you can, that you're going to use as a long-acting nitrate. You have basically 2 long-acting nitrates, that is ISDN and ISMN, that is isorbate mononitrate. These are the long-acting nitrates that we generally use. So there are 4 groups of drugs. Apart from that, you have other drugs like trimetazidine also, which also you can prefer, very commonly used for chest pain. So many drugs are there which you can prefer as a third line drug. So all these drugs can produce significant vasodilation, especially with special regards to nitrates, nicorandil, ranolazine. All these drugs can produce significant vasodilation. Because of that, they can get headache as a very common symptom. Headache is a very common side effect of all these drugs. Trimetazidine does not cause significant vasodilation because its mechanism is different. It does something else, which we'll discuss later on. And ranolazine, nicorandil, and nitrates can cause significant vasodilation. And they can cause significant vasodilation. And because of that, one of the important side effects of these drugs are going to be headache. That's very important. And it's very important that to understand that nitrates can cause something called tolerance over a period of time, especially long-acting nitrates have a higher risk of developing tolerance. So to avoid tolerance, if somebody asks you what you will do to avoid tolerance, if you want to avoid, you have to give adequate nitrate-free intervals. Adequate nitrate-free intervals, which means tolerance will be lost once you give a good amount of interval from using a nitrate. Then tolerance will be lost. If you don't give good interval, then tolerance will be not be lost. ISDN, then ISMN. This is isorbate dinitrate, that is sorbitrate, very commonly used drug, and ISMN, that is isorbate mononitrate. So avoid tolerance. You have to give adequate nitrate-free intervals. Nitrate-free, this is coming from a disorder called mumbaI disease, where it's a very common thing. You will study in many pharmacology textbooks where people who are working in fireworks industry in the olden days, that TNT and all will be there, no? Where they work. They use nitrates, potassium nitrate very commonly. So once they use nitrates, they used to get severe headache by Monday or Tuesday. Then Wednesday, slowly it will resolve. Thursday, headache will be very less. Friday, they won't even have headache. And Saturday, Sunday, they go home because it's a leave holiday. Then Monday, they come back again. They get exposed to nitrates again. They get severe headache again. So that's why it's called a mumbaI disease. Because what happened there in Saturday, Sunday is they have lost the tolerance that they developed over a week. And Monday, when they come back, they get a severe headache. The same principle we can apply here, because here we don't really want tolerance. There the patient wants, that the workers want tolerance, but here the patients don't want tolerance because we need continuous action of nitrates. Here headache is not a problem. Here we need that vasodilatory action to be continuing for a longer period of time. So for that, what mumbaI disease has taught us, because if you give a good nitrate-free interval, you are not going to develop the tolerance. So that is the idea behind that mumbaI disease, what it has taught us. So we are also trying to give an adequate nitrate-free interval. For example, the typical dosing of ISDN is going to be around usually morning 8 a.m. Then you can give at 1 p.m. Then you can give at 6 p.m. Which means the next dose will be given at 8 a.m. only, which means you are giving at least 12 hours of, not 12, I think it's 14 hours of nitrate-free interval. ISMN is more longer acting. So for example, if you use at 8 a.m., then you can give the next dose at probably 2 or 3 p.m. Let me write at 3 p.m. And here you are giving at least a 17 hour of nitrate-free interval, which is actually required for a longer acting drug like ISMN. So this kind of dosing schedule, what you're using is not a traditional dosing like BD or a TID or a QID dose. This is some very different and eccentric kind of a dosing. That's why we call something as a eccentric dosing protocol. Remember in exam, if they ask you what kind of dosing protocol that you follow, as far as nitrates are concerned, you're going to do something called a eccentric dosing protocol. That's what you're going to follow. And apart from that, at any stage of the disease, you can use one more drug called as short-acting nitrate. You can use one more drug called as short-acting nitrate. That is nothing but a NTG, sublingual NTG or a tablet form of NTG as a PRN formulation. PRN means use as and when required. Whenever you want to use them as a PRN formulation. So which means patient may get some kind of a breakthrough kind of a chest pain also. For relieving that particular chest pain, you can use short-acting nitrates as much as possible. Like how we use in bronchial asthma that short-acting bronchodilators, like what is that? Salbutamol or asthalin inhaler, use an SOS basis. Whenever you want to use it. So that's like that. Short-acting nitrate is like a PRN formulation you can use at any stage of the disease. Suppose if somebody asks, what if short-acting nitrates doesn't work? You rush to the emergency, because non-responsiveness to nitrates is a sign of an acute coronary syndrome. That's what you have to think about. So this is how you manage the patients medically. And of course, statins, what type of statins, if they ask you, definitely I'm going to use something called a high-intensity statins in this perspective, because this is an ASCVD. In any ASCVD, I have to use a high-intensity statin. Then final 10 minutes before you get a break is on the exercise stress test, because we have discussed in detail about the approach to the chronic chest pain. Then it's better to move on to something called a exercise stress test, because we have not yet discussed about the EST, exercise stress test. I mean, there are many types of stress testing are there, including the nuclear testing and all this stuff. But it's better that we discuss only about the treadmill ECG, because too much of information is also dangerous. So that is not valid for exams also. Let us discuss only on the treadmill ECG first. And yes, this is the most important. Other things are not really important, because if you want to discuss on cardiology, you can keep on discussing. Remember, cardiology alone can be discussed for 10 full days. That much information is there. Even then it will be insufficient, because adult congenital heart disease alone you can discuss for 1 full day. Valvular heart disease alone you can discuss for full half a day. And coronary artery disease alone can be discussed for 2 days. ECG for 1-2 days you can discuss. So it's too much. So we have to have an end at least. So let us discuss only the treadmill ECG and move on to the other diseases. So what are the things about the treadmill ECG? First, we need to know the indications. Then we know the contraindications. So as far as the indications are concerned, it's quite simple. As far as treadmill ECG is concerned, we know already it's a kind of a non-invasive testing. It's a kind of a non-invasive testing. So you're going to use it as a non-invasive test only. So indications can be either a diagnostic indication or I can use it for a prognostic purpose also. So for diagnosis, the best time where you can use for a diagnosis is for an intermediate probability. Yamini is asking, sir, will it be over today? 100% it will be over. Don't worry about that. So you're going to use in something called intermediate probability. Called intermediate probability. You're going to call it as intermediate pretest probability. Intermediate pretest probability of CAD. In this area is the best area where you can use a treadmill ECG. Number one. Then prognostic. So what about prognostic? Prognostic you can do in a patient who's having a known CAD to assess the risk of the patient, which means I told you, for example, after end Stemi unstable angina or after Stemi pre-discharge, you do X-ray stress test. So that's a known CAD patient where you want to tell the functional capacity of the patient and to assess a lot of other things. You do a pre-discharge X-ray stress test. So in a known CAD you can do, or you can do for a patient who's having a high probability or a low probability. Even for high probability patients or low probability patients, you can use this X-ray stress test for assessing the prognosis of the patient, which means you want to tell what risk stratification, what are the kind of the risk that the patient is going to have. But high probability is going to be more important. So it can be either diagnostic or prognostic. Diagnostic best is for intermediate pretest probability, prognostic for high probability, and also for a patient with a known coronary artery disease. That's all. So then you need to know the contraindications where you should not do the test. That's also important. So you have, of course, you need to know about the absolute contraindications, and we need to know about the relative contraindications as well. So what are the absolute contraindications? Acute coronary syndrome, especially in the first 48 hours, you should not even ask the patient to go to the bathroom. How can you ask the patient to run in a treadmill? The patient will surely die. In any patient with high risk chest pain, in textbooks, they will give us high-risk unstable angina, which means we are just meaning a high-risk chest pain, which I've told you already. What are the indicators of a high-risk chest pain? Of course, you cannot do in that setting. In acute pulmonary embolism, patient will be so breathless. Asking in a treadmill, you will be definitely cursed for life. Don't do that. Acute pulmonary embolism is definite contraindication. Then, if a patient is having a myocarditis or a myopericarditis or an acute pericarditis, definitely we are not going to do that because this is not good. Again, the patient will, a lot of reasons, patient will be sick, not able to give his full energy to run in the treadmill. At the same time, not needed, not warranted, because you know that the heart is having some trouble. So no need to do in this setting. So you can wait till the patients get better. And at the same time, if the patient is having a decompensated heart failure, again, it's unjustified to do in a decompensated heart failure. And patients who are having acute aortic dissection, you're not planning to tear the aorta into two. So don't do that. Acute aortic dissection. And at the same time, if the patient is having a severe aortic stenosis, remember, severe AS only is a contraindication. In fact, mild AS, you can do a X-ray stress test, no problem. Mild to moderate AS you can do, but only severe AS is a contraindication, not mild to moderate AS. Then, if the patient is having uncontrolled hypertension, then that becomes a contraindication once again. Then if the patient is having uncontrolled arrhythmia or any hemodynamic instability, is also going to be a contraindication. Any uncontrolled arrhythmia, especially tachyarrhythmias. For example, AF with rapid ventricular rate, atrial fibrillation, patient is having 150 rate, why you want to ask him to run in a treadmill? Or the patient is in VT, why you want to ask him to run in a treadmill? So hemodynamic instability, patient is in shock, no need. So these are some accepted and absolute contraindications. Then relative contraindications. Relative contraindications, if the patient is having a LMCA disease, it's a relative contraindication because sometimes they can go for global ischemia and they can die. But anyways, it's only relative contraindication. And moderate to severe valvular heart disease is a relative contraindication. Other valvular disease you're talking about, and electrolyte disorders like hyperkalemia, hypokalemia, relative contraindications. Then severe hypertension, not really uncontrolled, but severe hypertension more than 200/110 millimeters of mercury. is a relative contraindication. Then if the patient is having tachyarrhythmia or bradyarrhythmia, but that is controlled, that's a relative contraindication. And hypertrophic cardiomyopathy, obstructive or non-obstructive, becomes a relative contraindication. Then if the patient is having advanced AV blocks, relative contraindication. Then the patient is not mentally able to perform. The patient is having a poor will to run in a treadmill. I mean, that includes many of us who don't want to get up and run or walk. So poor will to do the test, that becomes a relative contraindication, which means mentally not fit. Like in the setting I told for a joke, but in the sense like patient is not in a very good mental state to accept our instructions and run in a treadmill. Or most importantly, if there is baseline abnormalities, baseline ECG abnormalities. Baseline ECG abnormalities. What are the examples of baseline ECG abnormalities? The most important is the left bundle branch block. That's going to be interfering with our analysis of the ECG, or it could be pre-excitation. Once again, same problem. It hinders with our ability to understand the ECG properly and analyze the ECG properly. If the patient is having a ventricular pacing, because it's going to mimic a LBB pattern. So same principle. So there's nothing big in that. And if the patient is already having an ST depression more than 1 millimeter, then why you want to do? Already the baseline is itself is suggestive of ischemia. Then why you really want to do a treadmill now? Then, or if the patient is on digoxin because it produces that characteristic hockey stick appearance, or if the patient is having left ventricular hypertrophy with repolarization abnormalities. So usually pressure overload. As I told you, pressure overload will produce ST segment with the depression with the T-wave inversion. I think I have told you this, ST segment depression with the T-wave inversion, they're going to produce, isn't it? So this kind of ST depression with T-wave inversion with LVH indicates a repolarization abnormality. So in that setting also, it's better to avoid the treadmill ECG because it's going to interfere with the interpretation usually. Clear? Of course, there were some other relative contraindications like pregnancy is a relative contraindication. You are not planning to deliver the baby in the treadmill room. So better to avoid in that setting. So physical disability is also contraindication. It can be absolute or relative. Suppose if the patient is not having both the legs, asking him to run in a treadmill is unjustified, of course. So a lot of contraindications are there, but I don't know whether to remember or not, because in exam, usually what they generally try to confuse the students is by asking all this stuff, isn't it? I mean, this is something like a very boring one. At the same time, you will definitely, they know that you will definitely miss one of these points to remember. So definitely they are going to confuse at that point only. That's how they're going to give. So remember, there is a difference between a good question and a bad question. If you want to really create a bad question, exercise test is contraindicated, then pharmacological test test can be done. Yes, I told you already. If the exercise test test cannot be done, if you cannot do a exercise stress, if the patient is not able to walk, then you are going to go for a pharmacological stress test only. We have clearly told, if the patient is not able to walk, means if the exercise test test cannot be done, then you have to go for a pharmacological stress test in this setting. We have discussed that already. So it's very easy to ask questions from this, because if you ask line by line, it's very difficult for any student to answer. You can't really answer. If I give any 4 from this, and if I just change severe aortic stenosis to mild to moderate AS, if I give this in the exam, it's very difficult to predict that this is the wrong answer. It's very easy to cheat you most of the times. See, that there are 2 ways to make a candidate suffer an exam. One is by giving very lengthy questions, by thereby wasting their time. Even though the questions are easy, by the end of 3 hours, you will not be able to complete the 300 questions. That is one way to make the candidate suffer. And second way to make a candidate suffer is by giving one-liners. One-liners are even more dangerous because they are like snakes. Like it's like a hit and run policy. Whether you know it. You don't know it. That's all. There's no option at all. There's nothing like in between thinking and all. How many ever mnemonics you study, how many ever things you study, the only the examiner knows that particular answer. You never can predict the answer in a sort of a one-liner unless and until you know it. That was the kind of pattern in one-liners. So that is even more dangerous according to me. At least if it's a lengthy question, you can have some kind of clinical scenario, and so guessing is also possible. For example, during my All India exam, one question came: amount of estrogen secreted by a woman in a month. What is the amount of estrogen secreted in a month? There was some answers like 15 milligram, 10 milligram, 20 milligram, and 25 milligram. You don't believe, this is a question I got. I couldn't really figure out where this question was coming from. I thought it's a SPM kind of question. PSM only has this kind of nonsense and all. So I thought it must be a PSM. So I thought like I'll be very logical in my thinking. I calculated, I wasted some 3-4 minutes. I thought like per month, what is the concentration of estrogen in an OC pill? Then I calculate for 30 days. Then I came to a conclusion that around 15 milligram is the answer. Then after later on, I started realizing it was completely wrong, because this question was not taken from a SPM book. This was taken from a physiology textbook, Genong. There was a table which tells how many estrogen, how much androgen was secreted per month, how much estradiol is secreted, how much progesterone is secreted, how much, like all this nonsense is getting secreted. I really don't know why you need to know how much per month she secretes. I don't know the answer still now. It's given in the Ganon. After that, I got frustrated and I didn't look at the answer only, but I know it is wrong. See, here also, someone, Dr. D is there. His name is only D, is asking what is the answer. I'm actually telling my struggles and you wanted the answer. Huh? Okay, pathetic. Kritika asking post-inferior MI with mitral regurgitation. Contraindication for a treadmill. No, it's not a contraindication. It's only relative contraindication. If it's a severe MR, you can consider not doing it because there is an MR already. If it's a mild, moderate MR, you can still go ahead with it, no problem. Because there, it gives a functional capacity of that particular patient again. So not a big problem. So, yeah, do these questions even have a point, making us lose the beauty of the subject? Yes, of course. Like this is very frustrating. Say a person like me has very poor memory power, basically. See, these all things, why I remember all these things, first of all, because I do it daily. One point, why I do it daily, so I remember certain stuff. And at the same time, there are some things which are interesting for us, so we remember it. And it makes some sense, but there are some things which doesn't make sense. And if an examiner wants to prepare a bad paper, and it's very easy to do it. You just take some statistical data, you just take some one-liners, you just take line to line from a particular textbook and just make a question. It's so easy. But I feel like asking a logical question is more difficult than taking a one-liner. Suppose if I hire some of you and ask you to make some 100 questions, and you want to take line by line from Harrison, it's easy. Tomorrow morning, you'll give 50 questions, and within 2 days, you'll be finishing 100 questions. But if I ask you to make logical questions, 100 questions, it will take 1 month at least. So probably that is why Indians are known for their laziness. That's why they're not making logical questions. At least 2020 was okay. 2021, let us see how it will be. I think it will be better and you will get more of clinical questions only. But till 2019, it was too bad. And my All India was okay, not very bad. But these kind of questions again made my day very bad. Next, I don't know. I don't know. Next supposed to come, but Corona, I think, is spoiled everything. And AIMS also, I think this was unprepared paper. As far as I know, what you got in AIMS June paper was very unprepared as far as I know, because they didn't ask the original standard one, what they were supposed to ask. They asked only the best of 4 kind of a paper only in the last time, which clearly shows that they did not have time to prepare a paper. And they just took some questions which was already there, prepared for the previous exams in urgency, and they just made a paper. It's very evident from the questions, type of questions they were asking. So don't take the June paper as a very serious one. And it's very unlikely that you'll get the same questions again, because I don't think that's a standard paper of AIMS. It looks as if they have taken very urgently. In last minute, they have prepared that. And because next time they might revert back to the original paper, like the match the following sort of a thing and all this stuff. So be careful. Don't rely on that June AIMS paper. Short subject was difficult. I don't know what you mean by difficulty. Difficulty means a lot of things. We'll discuss about that later on. And what are the protocols that you follow? What are the protocols that you follow? As far as the exercise test is concerned, you follow something called a Bruce protocol. At the same time, you have something called a modified Bruce protocol. And you have a Cornell protocol. And you have something called a Norton protocol. These are modified protocols. Norton protocol. Each and everything has a, like one advantage as well as disadvantage. But remember, Bruce protocol is the most stringent of all, and it's the best of all. If you are able to do, Bruce protocol is the best actually. Usually what they do is for every 3 minutes, they keep changing the speed as well as the slope. So it is going to mimic your running. That's what it's real one. Norton, N-O-U-G-H-T-O-N. That's Norton protocol. So Bruce protocol is something which I feel is the good one, especially for youngsters and people who can do that. Bruce protocol is the best because it has every 3 minute stage. I think even I have run for the Bruce protocols. I think many of you would have gone in the treadmill. So every 3 minutes, automatically you will go on to the next stage, and next step you will be moving on. And at every passing stage, your speed only will not increase, your slope also will increase. It's not about how fast you run, it's also about how steeper you run. It is also going to mimic a uphill running. So at least everyone should be able to do at least 6 minutes minimum. That is 2 stages should be crossed in Bruce protocol. If you're not able to do even 6 minutes of, walking or running in a treadmill, that's really, 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 really bad. Then you have to seriously assess what's happening. So we'll discuss about that in the next. Those who are completing all the stages of Bruce protocol is perfect, excellent. So anyway, they will not usually have any coronary artery disease. So Cornell protocol, usually this modified Bruce, Cornell, Norton protocol, all these things we use in patients who cannot really walk that much. So for example, very elderly people, or if you need you're doing a post-MI or a post-ACS, I can write post-ACS here. You want to do an exercise test. So you can follow these protocols because these are basically submaximal stress test. So that's what they will tell. So this is the usual maximal stress test, Bruce protocol, done for standard process. Submaximal stress test can be preferred in certain people, like very elderly people or patients who are suffering from post-ACS. Especially for post-ACS, you should not give a full EST. Usually we do only a submaximal EST. There are different protocols are there. Usually they will calculate the amount of energy spent in something called MET, that is called a metabolic equivalence. So usually 1 MET stands for 3.5 mLs per kilogram per minute oxygen consumption. 3.5 ml per kilogram per minute of oxygen consumption. So this is what you mean by 1 MET. So depending on your physical capacity, you can spend a lot of METs also in one go, or you will not be able to spend any MET because otherwise your coronaries go for ischemia and they won't work properly to supply this much amount of oxygen. So again, this is what they're going to calculate the METs. It's pre-calculated and it will be in the protocol already. Based on that, they're going to give the risk. That's all. Then you have something called a ramp protocol also that I forgot to mention. RAM protocol is a different protocol that is coming up right now. So just need to know the name of the protocols. The original protocol that we follow is something called a Bruce protocol, and we have other protocols like modified Bruce, Cornell, Norton, RAMP. So many protocols are there. Fine. What are the things that you're going to look for? Basically, you're going to look for the ST segment. That's what you're going to look for. ST segment. And where you're going to look for, already I told you, if the heart rate is more than 130, then you will look at ST segment at 60 milliseconds from the J point. If the heart rate is less than 130, we are going to look at the ST segment at 80 milliseconds from the J point. This is what we refer to as something called ST60 or a ST80. Whenever you study the exercise stress test, when they give something like an ST60 or ST80, this is what it means, which means you are going to see very commonly at 80 milliseconds from the J point, you are going to see what is the amount of ST depression that is happening. So what is the normal response? First, let us see what you mean by normal response. Normal response means you will have ST depression. It's not like you don't have ST depression. So I can write the ST80 depression that you see is less than 1 millimeter. And at the same time, you will be having a ascending slope. At the same time, you'll be having an ascending slope. That is more than or equal to 1 millimeter, more than or equal to 1 millivolts per second. So this is what we refer to as ascending slope. I'll tell you how to find out the slope in some time. So when you have an ST depression like this, not like this, like this. So this is kind of an ascending depression. So what we generally tend to do is at ST80 we put a point, and when you take a slope, we can calculate this. So in fact, the machine can calculate this slope actually. If we take this ascending slope, so I can calculate what is the slope actually. Basically, if this slope is more than 1 millivolts per second, then you don't have any problem at all. So anyways, fine. So if you understand, then that's fine. If you don't understand also, it's fine. So the depression should be less than 1 millimeter, or it should be an ascending kind of an ST depression or a upsloping kind of an ST depression, which means the ascending slope, if it's more than 1 millivolts per second, that is considered to be a normal response. Then you have something called an abnormal response. What do you mean by abnormal response? If you have a horizontal ST depression or a descending ST depression. If you have a horizontal ST depression or a descending or a downsloping ST depression, which I've showed you already. So in this setting, the J point and the ST80 depression will be definitely more than 1 millimeter for sure. At the same time, the horizontal slope, which means here it's not ascending, it's a horizontal slope. The horizontal slope is less than 0.7 to 1 millivolts per second, which means it's not 1 millivolt per second, it is less than 0.7 to 1 millivolts per second. Then what do you mean by descending ST depression? Here the ST80 depression will be definitely more than 1 millimeter plus the descending slope. The slope will be in the negative now. The descending slope will be less than minus 1 millivolts per second. Descending slope will be less than minus 1 millivolts per second. So in this setting, we call it as a descending ST depression. So descending and horizontal are very, very dangerous compared to the ascending. Ascending is considered to be benign. It can happen in tachycardia itself, but descending is very, very bad. And you have some gray zones in this. That is why treadmill ECG is not very great and all. Like suppose if there is a gray zone. So what do you mean by a gray zone? Suppose I'm having a ST elevation. Let us assume I'm having a ST80 of more than 1 millimeter, but the slope is ascending 1 millivolts per second. So this is typical example of a gray zone, which means you don't know really what to do in this setting. So the depression is more than 1 millimeter. Horizontal line have a slope. No. Horizontal means it looks horizontal to the naked eye, which means even though we draw like this, so this is not perfectly horizontal. So it will be like this only. So this is what we refer to as horizontal. So we are not talking about a horizontal means a straight line like this. Okay. That, and if you ask a doubt, that is also one reason why we give less than 0.7 to 1 millivolts per second. Less than 0.7 means it can be 0 also. Slope can be 0 also, of course. So your question is correct. He's asking like if it's a horizontal depression, mathematically speaking, the slope must be equal to 0. That's correct only. That's why we told it is less than 0.7 to 1 millivolts per second. If it's less than 0.7 means it will be 0 also, not a problem. But you give a cutoff, that's all, for that particular definition. Clear? I think your doubt is answered. So, if you have a gray zone like this, for example, if you have an ascending slope of more than 1 millivolts per second, at the same time, if you have ST80 more than or equal to 1 millimeter, then that becomes a typical gray zone. And in this setting, you have to assess the pretest probability of CAD and decide accordingly what you're going to do. If the pretest probability is low, then you can assess to be a low probability and you can leave him off. If it's intermediate probability, then you can do some other testing like nuclear imaging. If it's a high probability, then you can take them for coronary angiogram in that setting. So you have to assess based on the pretest probability. Suppose if the patient is getting another type of abnormal response in the form of a transmural ischemia, the patient is getting a transmural ischemia. So here you will not get an ST depression. Instead, you have to see something called a ST60 elevation. So patient will have an ST elevation, but there will be no Q wave. No Q wave formation. This is very typical because they're not developing an infarct. They're just getting transmural ischemia. that produce an injury current, that produce an ST segment elevation. And remember, as I told you, the ST depressions that we are seeing is not localizing to a particular area. It cannot localize. But the ST elevation, if you get, a transmural ischemia you get, definitely it will be localizing in nature. Very, very important points. All these things. Many times, that's why I told you ST elevation is very localizing. At the same time, ST depression is not localizing in the first place. If they ask you what are the specific leads to look for more often, for ST depression as well as the ST elevation, the V4, V5, V6. So these are the most specific leads. Among all the leads, these leads are going to be extremely specific, and this is where you are going to look for. V1, V2, V3 are mostly marginal and gray zone leads, especially if you get some isolated forms of STD changes in lead 2, lead 3, especially lead 2 and AVF. Especially more importantly, this AVF, like I've seen so many patients with STD abnormalities in AVF, which can be extremely benign. So these are all very non-specific leads, but if they ask you the specific leads where to look for, V4, V5, V6 is where your specificity is high. Clear? Suppose there are some specific, like problems that you can see. One specific changes that you can see is AVR elevation. Suppose if you have an AVR elevation, what does that predict? We had discussed that already yesterday itself. What AVR, day before yesterday, what AVR elevation predicts? AVR elevation usually predicts left mainstem stenosis, left mainstem, not occlusion, left mainstem stenosis, or very proximal LAD. Very proximal LAD. In fact, this very proximal usually means I'm talking about an ostial LAD. The point it branches out from the LMCA, that area you are having a stenosis. That's a very proximal LAD. So this is what is going to predict. But triple vessel disease, very poor predictor, AVR elevation. But anyway, LMCA stenosis is what is important here. Then there is something called a U-wave inversion. U-wave inversion. Usually U-wave, if it comes, it should be like this. If the U-wave is inverted, what is going to predict? And again, it predicts a very high risk and a significant coronary artery disease. If there is a U-wave inversion. And there are many areas where you can get something called a false positive result. Like for example, if the patient is having a baseline ST abnormality, patient is having an anemia already, patient is having cardiomyopathies, patient is on digoxin, patient is having hyperventilation during the test, and hyperventilation means they will have more breathing, but even before starting the test itself, they are having breathing, means that itself produce a little bit of hypocalcemia because of alkalosis, and that will, by the start itself, they will produce some changes in the STT. That's what hyperventilation can induce some false positive changes. Hypokalemia, other electrolyte disturbances, intraventricular conduction delays, left ventricular hypertrophy, aortic stenosis, severe hypertension, then volume overloaded states like CCF, MR, and patients who are having supraventricular tachycardia, mitral valve prolapse, all these entities can induce a false positive changes. So that is why treadmill ECG is not a very good thing at all, because there are so many conditions that can produce false positivity. The net take home point is it is going to have a poor sensitivity and poor specificity. Finally, what are the things that you need to know? So I told you what are the things that you're going to look for. Now we need to know when to terminate the test. When will you terminate? Indication to terminate. So again, you have absolute indication to terminate and you have relative indications to terminate the test. What are the absolute indications to terminate the test? Number one, decline in the BP more than 10 millimeters of mercury. Decline in the BP by more than 10 millimeters of mercury. That is actually a very serious, ominous problem, because the patient is actually going for LV dysfunction during stress. And that is the reason why paradoxically the BP is actually declining compared to that of increasing. At the same time, if it's associated with ischemia, it becomes an absolute indication. Suppose if the BP decline is there, but it is not associated with any ischemic changes. Without ischemia, then it becomes a relative indication to terminate the test. Then if the patient is having a severe intolerable angina, many times we have been using the word severe angina. After the break, I will ask you what is severe angina means. It is called as CCS 3 or 4. So what do you mean by CCS 3 or 4? This CCS means Canadian Cardiovascular Society grading. You're going to tell me later on what do you mean by Canadian Cardiovascular Society grading. 1, 2, 3, and 4 is there for anginal pain. 3 and 4 are considered to be severe angina. Patient is getting severe angina, absolute indication to stop the test. Then if the patient is having ataxia, syncope, and patient faints while running in a treadmill, of course, you are going to stop the test. And if the patient is developing signs of hypoperfusion like cyanosis, pallor, definitely have to stop the test. Otherwise, he will die on table. And if the patient wants to stop, because you have to respect the patient, which means they are feeling some difficulty. That's why they wanted to stop. So stop the test. And if the patient develops a sustained VT, remember, this is a very important point because in exam, they will give NSVT and they will give sustained VT, both in the options. Remember, NSVT is not an indication to stop the test. Sustained VT is an indication to stop the test. We know what is the definition of sustained VT and what is the definition of non-sustained VT, and we have discussed yesterday itself, so we don't want to discuss once again. Sustained VT is the indication to stop the test. Then if the patient is having ST elevation more than or equal to 1 millimeter. Clear? But remember, the important exception is AVR and V1. In AVR and V1, if you get ST elevation, you can continue with the test. But if elsewhere you get ST elevation more than or equal to 1 millimeter, it's an absolute indication to stop the test because the patient has developed transmural ischemia. And if you leave them to run continuously, and if you ask them to continue, they might end up with a transmural infarct and you can go develop an MI on table. So that's why when they get an ST elevation, it's better to stop. No need to continue further. So second, relative contraindication, if the ST depression goes beyond 2 millimeters, definite indication to stop. Then change in QRS axis, marked change in QRS axis, that indicates development of probably a ventricular ectopic and a ventricular tachycardia. Then a lot of arrhythmias like polymorphic VPCs. I told you polymorphic VPCs that are originating from different places. I told you this point specifically yesterday, that indicates a highly irritable myocardium. So they can end up with a ventricular tachycardia in a short period of time, and they can go for even VFib. So it's better to stop the test. And you have something called a triplet VPCs. Then if you go for a bradyarrhythmia, conduction blocks, if you go for a blocks during the treadmill, then any other bradyarrhythmias, or if you're developing a new supraventricular tachyarrhythmia, or if you're developing something called a triplet VPC, so which means it comes like this, 3 VPC, then you get a normal sinus rhythm. Then once again, your VPC will come in triplets. So why VPC coming in triplet is a problem? Because as I told you, 3 VPCs that happens at more than 100 to 120 per minute is a sign of a ventricular tachycardia, which means you are getting a non-sustained VT. So indirectly, they are telling if you get a non-sustained VT, that's a relative contraindication. We get a sustained VT, that's an absolute contraindication. That's all. So you can write triplet VPCs in the bracket. The books will give you non-sustained VT also. No, it's not like a trigemini. Trigemini is different. So remember, trigemini is VPC. This is a trigemini. So trigemini means every third beat is a VPC. That is a trigemini. If every second beat is a VPC, that is a bigemini. Then, of course, what do you mean by triplet VPC? Triplet VPC is different. If you get a 3 VPC, then you are getting a normal sinus rhythm. Then you are getting a triplet VPCs again. So this is a triplet VPC. So the triplet VPC is different from what you see at trigemini. So this is a triplet, comes in triples. So this is a trigemini. Both are different. Change in QRS axis is also indicating VT. No, not always. Change in QRS axis can happen in ischemia itself. Then why in lateral infarction, I told you, you get this kind of right axis deviation. Why in inferior infarction, you got a left axis deviation. I told you this yesterday itself. Ischemia itself can change the QRS axis. Significant ischemia. Then number 5, the patient develops severe fatigue. Patient develops shortness of breath. Patient develops a wheeze, leg cramps. All these things are relative contraindications, or probably claudication, which can indicate a significant peripheral vascular disease also. Claudication. Then worsening, chest pain, but like not limiting chest pain. It's getting chest pain, but not limiting. So in that setting, it's a relative contraindication. Then exaggerated hypertensive response. Exaggerated hypertension, which means one is too low, you're getting opposite paradoxical hypotension, or second is you're getting a severe hypertension, especially if BP more than 250/115. So 250/115. So this is an exaggerated hypertension. Though 7 relative contraindications and 7 absolute contraindications. This is what you're going to look for. And whenever you get an exaggerated hypertension, what does that mean? What does it mean whenever you get an exaggerated hypertension? Patient is having occult hypertension. Patient is having occult hypertension, which means even though the patient is having a normal baseline BP, this kind of exaggerated hypertension response tells you that in the future, the patient is likely to develop a hypertension. You call now it's like a pre-diabetes, where impaired glucose tolerance indicates that the patient can develop diabetes in the future. It's like a pre-hypertension kind of a thing. So if they develop an exaggerated hypertension during a treadmill test, there is a very high likelihood that they will become a overt hypertension in short period of time. So it might be variable. So it's like a pre-hypertension sort of a thing. So that has to be noted. Suppose if the patient is having a low BP, what does that mean? Suppose if they're getting a low blood pressure during an exercise test, what does that mean? What does that mean? Yes. It means only one thing. Actually, the patient is going for ischemic LV dysfunction. Because of stress you are giving, they are going for ischemic LV dysfunction. At the same time, it could be second possibility is there. If anyone tells they know cardiology better, what is the second possibility? If they have a response like this, they're having something called a dynamic LVOT obstruction, outflow tract obstruction. If I tell dynamic LVOT obstruction, there is one disease that should come into your mind. What is that? It is a HOCM. Yes, it can rarely happen in aortic stenosis also, but very commonly happens in HOCM. So if you have a dynamic LVOT obstruction, this is very likely. Your BP fall will be too much. In aortic stenosis also this can happen, but you don't have a dynamic LVOT obstruction. You have a fixed LVOT obstruction here, obstruction there. Or this can happen if the patient is already on antihypertensive therapy. Failure to increase the BP. The patient is having antihypertensive therapy or significant dehydration. All these things can tell you that the patient is having some form of problem like this. Then there is something called a chronotropic incompetence. So for that, you need to know what you mean by target heart rate. So what is the target heart rate you should achieve to tell that the test is satisfactory? That is 85% of the maximal heart rate. This is the heart rate that you have to achieve in any exercise test to tell that the test is satisfactory. So what do you mean by maximum heart rate? It is in males, it is 220 minus age. In females, it is 210 minus age. This is considered to be the normal target heart rate. So from the calculation, you need to achieve at least 85% of the predicted maximum heart rate for age and sex. So if you can't achieve that, that is what we refer to as something called a chronotropic incompetence. If you're not able to achieve, remember chronotropic incompetence is itself associated with poor prognosis, which means you're not able to achieve the target heart rate even after considerable exercise, means it's a poor prognostic sign. Clear? So there is another entity which I forgot. I think I've moved to something else. You have developed a UAV inversion. The third one, what I want to tell here is, if you're getting an exertional LBBB, exertional left bundle branch block, then again that indicates a poor prognosis. Very important. New LBBB, exertional LBBB, but it disappears on rest. So that's an exertional left bundle branch block. That's very, very bad. Then at the same time, we need to see something called a recovery of heart rate at 1 minute. Recovery of heart rate at 1 minute. So after, like 1 minute of rest, if you see the recovery, like it should actually should have come down. For example, within 1 minute, if your heart rate is probably around 170, my guess is it should come down by at least 140, 130 within a minute. So once you have stopped the exertion. Suppose if the heart rate is not coming down at all, and again it indicates a severe ischemia. That's why the heart rate is not coming down. So how will you calculate the recovery of heart rate in 1 minute? Suppose if you take the heart rate at peak, that is a peak heart rate that is achieved, minus heart rate at 1 minute after recovery, So if this is going to be less than 12 on standing or less than 18 on supine position, this is again a poor prognostic sign. This is not a good prognostic sign. So recovery of heart rate is very important. At the same time, we don't only see the recovery of heart rate, recovery of ST depressions. Post-exercise is also important. If your ST depressions don't recover, remember, usually it should resolve within 6 minutes normally. That is normal. Suppose if your ST depressions are persisting beyond 6 minutes, very, very poor prognostic sign. ST segment depression persisting beyond 6 minutes is not a very good sign. It's a poor prognostic sign. And at the same time, during the recovery, you are getting PVCs. So premature ventricular contractions. Again, this is a poor prognostic sign. So I told you many poor prognostic signs. So U-wave inversion, AVR elevation, exertion LBB, recovery of heart rate in 1 minute is not that great, which means it's not reducing at all. Recovery of ST segment, ST depression is not happening, which means ST depression is persisting beyond 6 minutes after rest. Then recovery, during the recovery stage, you are getting multiple PVCs. So all these things are poor prognostic indicators as far as your like treadmill exercise test is concerned. Finally, we are coming to a conclusion. There is something called a Duke's treadmill score. That's called a DTS. This is what we need to calculate. This is the most important as far as the entire exercise test is concerned. So that's called a DTS, Duke's treadmill score. So it says that the formula is there. Exercise time in minutes minus 5 into something called angina index. 5 into ST segment deviation. 5 into ST segment deviation. ST, I think either elevation or depression, anything. Minus 4 multiplied by angina index. So now everything you will be knowing, but only thing you will not be knowing is what do you mean by angina index. That's what you will not be knowing. Angina index is very simple. 0 means the patient did not develop any angina throughout the exercise. 1 is patient has developed a patient has developed a non-limiting angina. Non-limiting means the patient got an angina, but is able to continue with the stress test. I mean, it's getting a chest pain, but it's okay. It told like you can continue, no problem, despite getting chest pain. Number 2 is limiting angina, which means patient tells that I can no longer continue with the test and I have to stop the test because of that angina. That's a limiting angina. So now you are going to calculate what is the treadmill score. Let me tell the patient has exercised only for 5 minutes and he has got a ST depression of 2 millimeter and he had a limiting angina at 5 minutes, which means at 5th minute he stopped the test. So he did a test for 5 minutes, ST depression of 2 millimeter, limiting angina at 5 minutes. What is the score now? Can you tell the score? Yes, it should be the minus only. So minus 4 into 2 is minus 8 and minus 10 and it's only 5 minutes. So must be minus 18, minus 5. I think it's somewhere around minus 13. Minus 13 is the score. So definitely it indicates a very high risk. Duke's treadmill score of this is definitely very high risk because there is a risk stratification. So according to Duke's treadmill score, you can call it as a low risk. If the patient is having a score of more than or equal to plus 5, if the patient is having intermediate risk, you can tell the intermediate risk. If the patient is having a Duke's treadmill score of plus 4 to minus 10, you can tell it as a high risk if the score is less than or equal to minus 11. So the patient I told is having a minus 13 score, which clearly tells it's a high risk. It's less than minus 11. So any high risk disease, you have to straight away take for coronary angiogram. Intermediate, you can reassess later on, not a problem, or you can give a medical treatment in that setting. Low risk means you can just reassure the patient. And if the patient is an intermediate probability for CAD, then you can again give a medical treatment in this setting. So high risk means take the patient for coronary angiogram. That's what the non-invasive testing is going to do. So finally, let us summarize the factors of poor prognosis. What are going to be the factors of poor prognosis? Number one, of course, the first thing is DTS of less than or equal to -11, extremely poor prognosis. Then if the functional capacity of the patient is less than 5 METs, which means he cannot even do 5 METs of exercise, which means I can indirectly tell he cannot do exercise even for 6 minutes. Within 6 minutes, he got fatigued and tired, he stopped the exercise. And if he's having a low threshold for ischemia, or angina, which means he's getting ischemic changes in the ECG or angina at a heart rate of less than 120 BPM, he has not achieved the maximum heart rate, or he has got ischemia or angina at less than 70% of the predicted maximal heart rate, which means 85% he should achieve, or you got angina or ischemia within 70% of the predicted heart rate, that is HR max, or he has got ischemia or angina within 4 metabolic equivalents, within 4 meds. So this is again a high risk feature, only indicates a poor prognosis. And ST depressions, very severe, more than 2 millimeter, becomes extremely significant. And if he is getting multiple lead ischemia in multiple leads, which is typically defined as at least more than 5 leads. Usually whenever you get ischemia in multiple leads, indicates a left mainstem or a triple vessel disease. Either left mainstem disease or probably a triple vessel disease, multiple leads, ischemia. Then as I told you, if the ischemia, that is ST depressions, persist more than 3 to 6 minutes into recovery, in recovery stage, we discussed this already. If the ST depression or ST elevation, whatever, ischemia is persisting more than 3 to 6 minutes into the recovery stage, if the ST elevation happens more than 1 millimeter, except for the fact that if it happens in AVR, it's not a problem. It indicates LMCA disease, but apart from that, not a problem. But in other leads, if it happens, it's extremely significant. And as I told you, paradoxical BP response or abnormal BP response once again indicates a poor prognosis or a high risk disease, which means decline in the blood pressure by at least 10 millimeters of mercury, or you're not achieving systolic blood pressure of at least 120 millimeters of mercury during your exercise test, which means the blood pressure remains below 120 millimeters of mercury despite doing exercise tests. It indicates a LV dysfunction in that perspective. Or if you're getting a sustained or a symptomatic VT. Symptomatic or a sustained ventricular tachycardia is also a very important sign of a poor prognosis. And we have many other things also. Like I think told you, if you get VPCs in the recovery phase, that also indicates a poor prognosis. So which you want, you can write. VPCs during recovery, ventricular premature contractions during recovery, poor prognosis. Of course, the most important of all is the DTS. Clear? And one more thing also, I mean, you want to tell increased QRS voltage. You know why increased QRS voltage during exercise is a sign of severity? During exercise. Why? Anyone can tell? Yeah, you can write U wave inversions also. I mean, I just told only whatever I remembered. So U wave inversions are important. So why? Can anyone tell why increased QRS voltage during exercise is a poor prognostic sign? Why? It indicates an ischemic dilatation of the heart. So they are going for ischemic cardiac dilatation, ischemic LV dilatation. So that is the reason why that is a poor prognostic. Unequivocally, your DTS score is the most important and very commonly will be asked in exams, because if you take the last 3-4 years paper, at least one question is there on exercise tests. So it's worth spending that 1 hour, that whatever we have discussed. I think we have discussed whatever is needed for the exercise tests, right from the indications to the contraindications to the protocols to the things what you have to look for in the EST, then when to terminate the test, what do you mean by target heart rate and what do you mean by chronotropic incompetence and what are the factors of poor prognosis. And the most important, I believe the next year question is going to be on the Duke's treadmill score only. They will surely ask the DTS. That is the only thing that they have not asked till now. One UPSC exam only has asked in 2018, I think, regarding the DTS. But apart from that, no exam has asked the DTS aims or all India. So I believe that that will be the next one. I think they're regularly asking one question on exercise test. So you need to know about treadmill test for sure. There might be a lot of technical data, but still it's very important to know. Clear? Do you understand? Is there any doubts in this so that I can clear the doubts in 2 minutes and they can move on to a short break? Do you understand? See, how you are remembering all this means really I practice. What topics may be left in cardiology? So we have a short session on aortic disorders. We have a short session on heart failure. We have a short session on cardiomyopathy and important disorders like tamponade, constrictive pericarditis. And that's all. I think we will be winding up with that. And maybe if there is time, I'll do some clinical cardiology topics also. I mean, only important things, important stuff. I'll not be giving anything. Hypertension you can cover in nephrology also, not a problem. If you want, I'll cover here. See, Madhusudan finally coming to the pulse only. Pulse, sir. That needs a lot of understanding. Next major topic, endocrinias. If possible, tomorrow I'll try to take some 3 hours in the evening. If possible, I will tell you. What is CHD? I don't know what is CHD. What is CHD? You are talking about a congenital heart disease. See, I'll split the cardiology into two. So people who are interested in attending, they can attend MMS 2.0. I'll try to take all these things in 2.0. I'll cover congenital heart disease because pulse itself needs 3 hours. How will we be informed if we have class tomorrow? In my Telegram group, of course. I'll inform tomorrow morning in the Telegram group. If possible, I'll take a class by evening. Some 2-3 hours I will take to cover the portions. Not a problem. Okay, now we can go for a break. So remember again, factors of poor prognosis, DTS score less than -11. Then of course you need to know about your ischemic thresholds and all, and how the ST segment depressions going into the recovery stage, and the PVCs that are happening during recovery, U wave inversions that are happening in the exercise, or the patient is not able to have a good functional capacity, paradoxical drop in the BP, or the failure of the patient to increase the BP to more than 120, chronotropic incompetence, de novo left bundle branch blocks, development of ST elevations more than 1 millimeter, ST depressions more than 2 millimeter. All these things are going to be a problem. Group name is Dr. Dilip's MMS. I think this is the group name. If you people want, you can join that group. Okay, so let us go for a short break and we'll come back at 7:45. Now break. Bye-bye.